Okay, members, we will get back on track here, and we have Representative Zerwas coming with House File 1208. And Representative Zerwas will move that House File 1208 be re-referred to the Committee on Civil Law and Data Practices. And Representative Zerwas, I understand that you do have a DE amendment.
Thank you, Madam Chair, members. Yeah, I'll move House File 1208, and then there's a DE2 to get the bill in the shape in which I'd like to discuss it today.
Okay, members, we have the DE2 amendment, and we will move that amendment so that we're discussing the bill in the order that the author would like it. So, member, all those in favor of the DE2 amendment, please signify by saying aye. Oh.
Aye.
Okay, I just want to make sure members are getting the DE2 in front of them. So,
Oh, okay.
So members, do we have it?
Why? It already passed.
Representative Liebling.
Madam Chair, maybe while we're waiting for the DE2, I'd like to bring up another issue, if that would be okay, just in terms of the committee. So I understand that on Monday evening, we're hearing quite a few bills that are very substantive. And I understand that we have until 10 a.m. to get amendments in. And I think this might be a good time to suggest that as chair, you might wish to waive the 24-hour rule, period. Because as you recall, when I was chairing this committee, and the majority at that time, the DFL, imposed the 24-hour rule on the floor, your members were very, very upset about that, as I was. And I responded by not enforcing a 24-hour rule in this committee. And I think that was very well received by your members. No one abused it. It was very fair, I thought, and we got along all very well without that. And now I really feel that having even a 10 a.m. deadline for these bills, I mean, we, of course, will work hard to get our amendments done as soon as we can, but I think we're now under very tight deadlines. Things are really speeded up, and many committees actually waive the 24-hour rule as they get close to deadlines just because it becomes impracticable. So I would just like to respectfully suggest that you might want to consider doing that as well, because really it's important, I think, for all members to be able to get their amendments done. So thank you.
Thank you, Representative Liebling. And I do understand we do have a full night in front of us on Monday night. And it would be my preference. I do think it's important, especially with the complicated nature of, certainly every committee has tough topics to deal with, but I do think sometimes the complicated nature of things that we deal with here in Health and Human Services, it serves our members well to be able to kind of know what we're dealing with going into committee. So I would consider, if there is a issue of getting amendments done by 10, I would consider and talk with staff about maybe moving that to noon, but I would prefer members to have at least some time and option to know what's coming somewhat in advance of committee. And so we can talk about that as we conclude today, and we'll make sure to communicate to members what time that will be. Certainly want to make sure members have enough time to get their amendments in and want to respect that, but also do value having members knowing what's coming before we come in and time to discuss it within their respective caucuses. Representative Loeffler.
Well, thank you, Madam Chair. And I think that, you know, you've been working hard to kind of make it work for everyone, but I really think, you know, when you don't get more lead time, like if this had been announced on, you know, Wednesday even, or Thursday, that would have given us more time even to talk with staff about drafting. But if we're going to be in committee here all day with the staff who, you know, from House Research and elsewhere, who would help us with those things, you know, to give them such a tiny window at the front of the week to look at potentially amendments on 6 different bills, you know, we have to be respectful of them. They do a great job. We appreciate it. I love our House Research staff, but, you know, they can't do miracles either. And so to the degree that you can get committee agendas out much faster, it works for a smoother process for absolutely everyone around the table, but it particularly makes it much more manageable for our staff, who I think we put in some really compromising positions.
Thank you, Representative Loeffler, and I take responsibility for that, and we will try to get the agendas out, and I'll be in touch with House Research. I certainly don't want to put unrealistic expectations on them, and I know none of us do. And several of the bills on Monday night do have multiple stops next week. That being said, I realize there are ones particularly pertinent to this committee, and so we will have a couple conversations this afternoon and make sure that we can try to meet the needs of everyone as best we can, so that we can have a productive conversation on Monday night. Representative Liebling.
Sorry, not to prolong this. I know we've got a lot to do, but I just want to respond a bit to your comment about wanting to let members see the amendments ahead of time. This is a double-edged thing. And my comment on the floor about doing this on the floor is that it really stifles, everybody sees it ahead of time, so everybody can talk about it with their caucuses ahead of time. Everybody can make up their mind ahead of time. I view that as a problem. I view it as a bug, it shouldn't be a feature, it's a bug. And in committee, and when we have that same rule in committee, it makes it even worse because it pushes back and back the actual opportunity to think about something. And I think in committee, we have a pretty good working relationship here, and that we look at the bills and we think about it. And if everything has to be thought about and decided ahead of time, I think it really stifles the problem-solving nature of the committee process. So I just wanted to push back a little bit. I realize that when you're in charge, it's nice to know so that you can tell all your members, here's what it means and here's how we're going to vote. But I don't think members need to be told, or should always be told, what we all think it means and how they should vote. I think it's good if you come to committee, you listen with an open mind, and then maybe there's a little bipartisan thinking and problem solving that isn't always about figuring out which side your caucus is going to be on. So thank you, Representative Mack.
Thank you, Representative Liebling. Representative Kelly, to that point.
Thank you, Madam Chair. And I appreciate Representative Liebling's intent there in having good conversation. But the problem is we're heading into deadline week, and I know our Transportation Committee as well will be meeting on Monday. So for a lot of our members, they're pulled in several different committees. So to just have that time to understand what even the discussion is going to be, I do think we need that time to understand what amendments are coming. And you giving some leeway there on it, I appreciate that, but I would request that all of our members are able to know what's coming there as well. Thank you.
Thank you, Representative Kelly. Members, we will follow up with communication just so we all have the right expectations going into Monday this afternoon. So with that, Representative Zerwas, 2-year bill, House File 1208, and I do believe that all members have the DE2 amendment in front of them now. And so members, we will vote on the DE2 amendment to get the bill in the order that you would like. Members, all those in favor of the DE2 amendment signify by saying aye. Aye. Those opposed, no. The motion prevails. Representative Zerwas, 2-year bill as amended.
Thank you, Madam Chair. Members, good afternoon. Hopefully everyone had a good lunch. I know I had a few minutes to go upstairs. I bit the ear off my 1-pound gummy bear. It was a great lunch. So House File 1208 deals with health disparities, members, and it's really one of the most challenging problems that Minnesota's overall excellent healthcare system faces. While Minnesota enjoys among the nation's highest ranking in overall health, quality of care, and access to health care, we also have among the nation's largest disparities for our racial and ethnic communities. For example, according to Wilder Foundation report in 2010, the percentage of low birth weight babies for white mothers in Minnesota was 3.7%, while the rate for African American mothers was 9%, and for Asian mothers was 6.4%. There are many other examples of this. I think a timely one is that the statewide average of percentage of patients who receive optimal diabetes care is 69.9%. The rate of African Americans that receive optimal diabetes care is 56%. But if you really drill into that and look deeper, the rate of Somali-speaking African American patients is only 18%. And so unfortunately, in our current data system, there is only the category of African American, and it doesn't delineate that out further. So the data does not reveal a true source of the disparities for the subgroups, whose quality care is a little bit different than the larger average. So the bill addresses three major issues. First, current state healthcare data does not fully reveal healthcare disparities because the data is not broken out by race, ethnicity, and language. Beginning on July 1st, 2016, the state's quality reporting and measurement system would be broken down by these factors. By January of 2018, other socio-demographic factors that correlated with health disparities and have an impact on performance on quality identified by the Commissioner of Health would also be stratified. Second, the current system penalizes providers who serve low-income, diverse populations because they may be reported as low-quality providers based on the patients they serve rather than the quality of service they provide. And thirdly, members, increasingly provider reimbursement is being tied to quality, which everyone agrees with. The bill would require the Commissioner of DHS to work toward a payment system that takes into consideration the higher cost, higher complexity, and the resources needed to address health disparities. The bill requires the Commissioner to report back, by my 35th birthday, December 15th, 2015, so it'd be a great day for everyone. And so, even though this bill deals with healthcare data, I want to make sure this is pretty clear, because I know there's going to be some testimony with concerns about data. It does not change Minnesota's health data, privacy, or security laws, or give the state any new authority whatsoever to collect data. This bill addresses how data that can be collected under existing law is organized and reported out. And so if you have the DE2 in front of you, if you can all turn to page 2 of the DE2 and look at line 2.9 through 2.13, nothing in this clause expands or changes the Commissioner's authority to collect, analyze, or report healthcare data. Any data collected to implement this clause must be data that is available or is authorized to be collected under other laws. Nothing in this clause grants authorities to the Commissioner to collect or analyze patient-level or patient-specific data of the patient characteristics identified under this clause. So members, just to be perfectly clear, this is a bill to help with data and healthcare disparities, but by passing this bill, we are not in any shape or form giving the Department of Health or DHS any broader or different or expanded authority for data collection in the aggregate, and certainly not in patient-specific. And with that, Madam Chair, I think there are some testifiers.
Thank you, Representative Zerwas. We do have a handful of testifiers, so we'll move through those first and then take members' questions. So our first testifier is Mr. Scandrett. Welcome to the committee. If you could introduce yourself, and we're going to try to keep testifiers to about 2 to 3 minutes. So welcome, and thank you for being here.
Madam Chair and members of the committee, my name is Michael Scandrett. I'm here on behalf of the Minnesota Healthcare Safety Net Coalition. The coalition represents Minnesota's nonprofit providers in various places across the state, whose primary mission is serving low-income populations, and they end up being very diverse populations or with other challenges. So that's what they are in business to do, and those are the populations they serve, and that's why this is a really important issue for those particular providers. And they represent the full spectrum of care: mental health, primary care, dental, safety net hospital services as well. And so I know we have limited time, and you're having a very long day, and Representative Zerwas did such a great job. I cut off about half of my testimony, so we can keep it more brief. So I don't want to repeat the things that he has already said. So just a few things to point out, and I will maybe just at the beginning repeat one thing, and that is to say we have worked very hard to be sure that nothing in this bill changes the data privacy laws, allows any additional data to be extended. We have heard concerns about that, so we've continued to add more and more language to be explicit about that point. And if there's anything more we need to do to make that clear in the bill, we'd welcome more language to add to that. But we're talking about the existing system, the existing process. We're not changing that. Data that's already being collected. In fact, in your handouts that you have from the Safety Net Coalition, you can see a pilot project example of the kind of data that we're trying to show where it can break that quality data down into additional categories, and that's where you can see how various racial and ethnic communities have very different experiences in terms of the quality of care. We just think that's important to know. The providers need to know that. The communities, the legislators and policymakers and state agencies need to understand what's going on, because if you just look at that African American category, you don't realize that there are some within that that are fairly close to the statewide average and others that are very low, and there are very different reasons for that. So as soon as you understand what's going on, you can do a better job of bringing the quality up for those that are experiencing lower quality. The other thing is just to kind of emphasize, too, that Minnesota has really been a leader and has done an amazing job in developing ways to measure quality, to understand what quality is, and it's easier for us than any place else to be able to go and look at compare clinics or hospitals and understand what's going on. And that's really important. But the one issue that we face with that, as quality becomes more and more a factor of payment, or even eligibility to be in a health plan network or participate in public programs, we've got a benchmark up there now. You need to meet these quality standards, and that's important too. The problem is the current system does not distinguish well between the expertise, the clinical skill and quality of the providers and the physicians at the clinic, and the characteristics of the patients as they walk through the door. And there are some examples where certain populations that may be served extensively by a particular clinic come in the door with conditions or circumstances that lead to a lower quality score, even if the clinic is doing even perhaps more than many other clinics in trying to bring up the quality of care. And the one example is in the diabetes measure that we have for optimal diabetes care. One of the criteria, and it's an important one, is does the patient smoke or not? And that's really important, but if you serve a population with smoking rates of 50%, and another clinic serves a population with a statewide average closer to 14%, you're going to fail all the time on most of your patients, even if you're doing a better job than anybody else in getting to quit smoking. So what we're trying to do here is to get the data so we can see the differences, and then use that data to create ways to report that so that we're being fair to all the providers. We're not disqualifying the very clinics and hospitals that are doing more to serve those populations, that are in the mission to serve those populations, just because the measurement makes them look like a poor provider that doesn't meet those averages. So again, as Representative Zerwas said, the bill kind of has those three components. Let's break the data down more and understand what's going on. Let's adjust those quality scores to reflect those factors. And the third is you're kind of just thinking, too, that often it takes a lot more resources for clinic to serve those populations that may have language barriers or cultural barriers or have a lot of poverty issues going on. And we should look at our payment system so that we can kind of more fairly direct the resources so that it kind of, we want to bring everybody up to the same outcome level and the quality level, but some people are going to need extra time and extra services to get there. So with that, I'll take any questions that you have, and then we can move on to other.
Thank you so much. We'll keep moving on with testifiers, but have you nearby if there's any questions. Thank you so much. Our next testifier is Twyla Brace. And on deck will be Justin Bell. Welcome to the committee.
Thank you, Madam Chair, members of the committee. My name is Twyla Brace. I'm president of Citizens Council for Health Freedom. As I start my testimony, I first want to draw your attention to the initial version of the bill before the amendment, because you'll find something there that you won't see on the amendment, but is actually on the bill. So if you look on the bill, 1208, as introduced, in the short summary, you'll see a health equity data plan. Now that, of course, continues in the first engrossment, which is what has transpired as of this morning, but you don't actually see it. Now, nowhere in the bill does it mention a health data equity plan, but when this was testified on in Senate and that question was asked, they said that it is implementing part of the Health Department's health data equity plan. I don't believe any of you have seen the Health Department's health data equity plan, and it's good for you to know that such a thing is being implemented. Now, the second thing is about the quality measures. We have always been concerned about the so-called quality measures because it's really a compliance measure. And what we're seeing here today is that there's just not enough data that can be collected on anyone to try and figure out how to parse out what is quality. What is quality for one patient might be different for another patient. And what you might have to do in order to really understand the differences in outcomes is you'd have to be even more intrusive, looking at compliance, lifestyle, religion, culture, spending preferences, the varied value of healthcare, genetics, family dynamics, structure, and more. So when it is stated here that we're not really doing anything other than is already being done before, first of all, if you have to bring a law to make changes, clearly something is being done differently. And if you look at the language now to the amendments, if you look at the language on 1.23, you'll see the fact that the commissioner, I'm sorry, 1.22, the commissioner may require measures to be stratified by other sociodemographic factors that, according to reliable data, are correlated with health disparities. Now, the question is, do you all understand what a health disparity is? Is there a really good definition for what a health disparity is? And what is reliable data? How much data do you have to have on someone to know why their outcome is different than somebody else's? We're not encouraged by the idea of the pilot projects because really at the end of the day what you're doing is you're requiring the hospitals and the doctors to collect and require their patients to provide this information, divulge this information. You're going to make it more forceful on the part of the hospitals and clinics to try to get their patients to fill out these questions that give them this information, whether it's race. In time, it might be gender. It could be, what their income is, what their title in life is, where do they work, where do they live, what are all the socio-demographic information that could be required by the health department. So this actually is new because the commissioner gets to decide what will be reported. Now, I want to draw your attention to line 2.8. Where it says to build upon. Clearly, we're making something new if we're building upon the data stratification methodology. And this is of the contracting agency. So now I want to bring you down to 2.12, where it says this grants, nothing in this clause grants authority to the commissioner to collect or analyze patient-level or patient-specific data. However, in January 2014, the health department added a button to the Minnesota Community Measurements website saying that the clinics could press that button and therefore give patient-specific data to the health department. And patients have no say about this. And now we have more data that's going to be collected according to whatever the commissioner decides. And the last thing I think I'll draw your attention to is line 3.8. Line 3.8 is a risk adjustment system. It's important for you to understand that the Affordable Care Act requires a risk adjustment system. That means individualized, actually the regulation says individualized risk scores. So all of us being scored in order to share, to change money between health plans. This is part of the Obamacare 3R regulation. And I suppose the last thing I forgot, there's one more thing. If we go to the last page, line 6.5, there's actually going to be money for the development of the quality incentive payment system specified in this new language. So indeed, there is something new being created here, and it is going to take more money, and there's going to be more money for the development of the risk adjustment system. So there are new things happening in this bill by virtue of the fact that there's new language, but also by the virtue of the fact that there's more money. And so I leave you with that, and just to say, as a patient advocate, it is simply wrong to require patients to divulge this kind of information, to profile themselves, to put themselves in boxes for payment. And it's wrong to force practitioners to have to do this to their patients and to make their payment according to how successful they are in forcing their patients to provide this kind of information. Thank you.
Thank you, Ms. Braze. Our next testifier is Justin Bell. And the next one will be Joel Euland. Welcome to the committee. If you could introduce yourself and proceed.
Thank you, Madam Chair and committee members. My name is Justin Bell. I'm the Government Relations Director for the American Heart Association here in Minnesota. If I could point your attention to a letter that you had in your packets from other organizations like ours that are supporting this bill, the American Cancer Society, the MS Society, the American Diabetes Association, and others. Our organizations do programmatic work on the ground in community health initiatives. We're making progress with heart disease and stroke. You might have noticed that earlier this year, the CDC announced that stroke has dropped from number 4 to number 5 in the leading cause of death in America. And we're hopeful that in the next 1 to 2 years, we'll be able to celebrate heart disease no longer being the number 1 killer of Americans. But even though we're making this progress, the disparity gaps in these conditions continue to widen. For example, if you're African American, you're twice as likely to suffer a stroke than your white neighbors. Organizations like ours invest resources and time into community health programs that are targeted at these populations and these health disparities. But one of the struggles we continuously have in this area is the lack of better data reporting around race, ethnicity, and language. The example I gave earlier on stroke in the African American community doesn't show that those outcomes and risk factors are completely different for native-born African Americans versus African immigrants. Or as our organization is preparing to launch community health initiatives around hypertension in the Asian community, those risk factors and outcomes are totally different if you're talking about the Hmong community versus the Vietnamese community. So breaking this data out into further categories helps organizations like ours with our programmatic community health work on the ground. House File 1208 is a good step in the right direction. We're very thankful for the Safety Net Coalition for advocating on this issue, and thankful to Representative Zerwas for being a leader in the legislature.
Thank you so much for being here. Joel Euland. Welcome to the committee.
Thank you, Madam Chair, members of the committee. My name is Joel Euland. I am here on behalf of UCare and also on behalf of the Minnesota Council of Health Plans. I want to thank you for the opportunity to testify on this bill. This is a bill that we have been working with with the Safety Net Coalition as well, and we've had a number of discussions in the last few weeks since the bill has been introduced. From our perspective, we do support the concept of what this bill is trying to achieve. This is something that the health disparities that we face are very significant. And I'll speak for my own health plan and say that we serve quite a number of people who are underserved in these areas. And we want to try to identify better ways to be able to manage this population so that way we can better serve them and make sure that they're getting access to the health care needs that they have. I think we really appreciate some of the amendments that were made in the DE2 amendment. Specifically, there was some adjustments that were made in the timelines to when some of the components were going to be implemented. That was something that we had sought, and we were very appreciative that the Safety Net Coalition was willing to look at that and make some adjustments to that. I think from our perspective, one of the areas that we are still taking a look at is just an area of risk adjustment and how the data could be used as you look at that. One of the conversations that we've had with the Safety Net Coalition in the last few weeks is that we were aware that there was a report that was coming from the Department of Health that was dealing with some of the quality issues and sociodemographic issues that are very key to this type of a bill. The report was actually just issued yesterday at 4 o'clock. And so we haven't had time to really compare. There was about 11 different findings that we saw in the report. We haven't had a chance to really compare the report that came from the Department of Health and figure out how that plays into this type of bill. And so what we've done is committed to the Safety Net Coalition that we're going to continue to work with them, try to identify where are some good solutions maybe that the Department of Health report recommends, and then also see if we can have a recommendation by the time it gets to Representative Dean's Finance Committee that we could possibly have in the form of an amendment. So at this point, that's where we're at. Thank you.
Thank you so much. Our last testifier is Dr. Lynn Ogawa. Welcome to the committee.
Madam Chair and committee members, my name is Lynn Ogawa, and I'm a family physician working for Westside Community Health Services. Westside is the largest federally qualified health center in Minnesota and serves a diverse, underserved population. I'd like to share just some brief data about our population. We serve between 30 and 35,000 unique patients annually through over 130,000 visits at our 18 medical and dental sites. Approximately 80% of our patients are from communities of color, including Asian, African American, American Indian, and Latino. Over 90% of our patients have incomes below 200% of the poverty level. About half do not have any insurance, and about half are best served in languages other than English. I've practiced in Minnesota and in Minneapolis and St. Paul for 20 years. I practiced in North Minneapolis for 7 years at Fremont Community Health Services, another FQHC. Then I joined Fairview Health Services in South Minneapolis for 4 years before returning to an FQHC 4 years ago. We need better equity in provider quality scores in the statewide quality reporting and measurement system. Specifically, there needs to be more robust risk adjustment to the system's measures as they are used to evaluate and compare providers. The current system doesn't recognize the differences in the community's health statuses at baseline, nor take into account the socioeconomic or other influences that aren't in my control as a physician. This became clear to me as I changed places of employment and communities of care. When I was at Fremont, my quality data was quite low, and I was a below average performer. When I moved to Fairview, my quality data was significantly higher, and I received incentive pay. I received accolades from Fairview and Minnesota Community Measures for our scores in diabetes, and I was a top performer. Now, at Westside, my scores are again, unfortunately, among the lowest on the site, and I am, again, a below average performer. I'm a strong supporter of quality improvement. In fact, I returned to Westside specifically to help lead our quality program after having served on the Quality and Informatics Committee at Fairview, because I saw the evolving healthcare market and was already concerned that the system was disincentivizing providers from serving patients with lower health outcomes and more needs. The current system is at risk for removing resources from the communities I serve. Specifically, those who already face more health inequities, have higher rates of health disparities, and have been underserved by the healthcare system. We need changes to the measurement system so that we providers and our patients are not penalized and eventually left out of the healthcare system again. I urge your support of the HF1011. Thank you.
Thank you so much for being here. Is there anyone else in the audience who wants to testify for or against? Welcome to the committee. If you could introduce yourself and proceed.
Madam Chair, members, my name is Aidel Abdul, and first I want to thank Representative Nick Zerwas for writing this bill. And I just want to say, so I support the bill, but I want to talk as a black woman about disparity. Somebody had said before, what is disparity? Disparity is Michael Smith, Caucasian, Michael Smith, a minority, goes to the same doctor, gets different services. That's all there is. Disparity is unequal access. And so, and there was an article written recently that said if Minnesota is so good about, and it's good, it's one of the top 10 for healthcare, it's one of the top 10 for education, but the article said, and Mayor Hodges replied, it said, if Minnesota is so good, why are minorities failing? And why are African Americans failing? Why is it so bad for us? And I appreciate the data collecting, I think it's important, but you know, we are a nation of immigrants, and so my mom has diabetes. Many Somalis, as President Zerwas said, have diabetes because sugar is like our middle name. You know, not me, just them. But, and so should we count every immigrants? Should we say, well, then there is the African American, and then there's the Kenyan, there's the Somali, there's the Zambians, there's so many. I prefer that we make sure all Americans have access to equal services. And so I ask the health department to also do something about this data. So we're not just collecting data, but what do we do? Because we already have data. We have that data for minorities are failing in healthcare. So what is the Minnesota Department of Health doing about it? And the charge of the state health department obviously is assessment, assurance, and policy. And the middle part is assurance. How do you make sure patients of all colors understand the medical condition they have? For example, if I can give you an example for autism, when we started with Governor Palente's health department, we went to Commissioner Magnana and we said, we're not interested in you collecting data. We already know minority kids get diagnosed with autism age 7, 3-4 years later than Caucasian parts. What we want to do is educate providers, increase providers of diversity, so we've got more Somalis now are becoming therapists. And we want you to educate providers. So she did a conference for providers of how to deal and how to diagnose and how to refer intervention and services for children from Somalia that have autism. She also did a conference for families, so they could do conferences or workshops for people like my mother. She doesn't speak English, but she has diabetes. That does not mean she's less American. And so collecting more data, okay, important, but then what happens? How do we as a state, and particularly the health department, be responsible for that? Because now a lot of Somali families, they know they are not waiting till their kid is 7. They're getting the services at 2-3 years old because the health department took charge of the health for all Minnesotans. So I support the bill. I support you, obviously, and Abler, who's pushing this. But I would like the members to be cognitive of that it's not just about collecting data. It is also about access to equal services for all Americans, irrespective of their race or ethnicity. Thank you.
Thank you for being here. Members, are there any questions? Representative Quam.
Thank you, Madam Chair, and I want to thank the presenters and all the people that gave data, but I did have some queries. From IBM Motorola quality, I've been through black belt training, and I know that in order to do a quality system, you need data, and so on the, Michael Scandret, his group had this wonderful chart with all the different languages and the percentages and et cetera. But on 33, they've got Southeast, and they show or reference less than a tenth of the languages, because I think there are over 80 languages spoken in the households in Rochester, which is the third largest city, and other cities in the Southeast have diverse minority makeup. And then page 104 doesn't even list Southeast region. So I just was hoping to get a better idea of the completeness and thoroughness of the data of which we're going to utilize for a quality system.
Mr. Scandret.
Yeah, Madam Chair, in responding to the question about the data, what you're seeing in front of you is an example of what we hope to get to, but it's a pilot project and not all providers are participating and it's just being tested out. So there isn't as much data as there would be if we kind of move this to be consistent statewide. But there's also then communities where the numbers aren't high enough to be statistically valid. We don't want to report numbers when there are too few patients for those populations. So the idea is, every community, every provider, you'll have data if it's valid data. There's enough patients to be able to trigger a report on that. But also, again, we don't have all providers participating, and the consistency of the reporting also is not at 100% yet. So the idea of the bill is let's be consistent, let's be statewide, and then still there may be small enough numbers that we wouldn't be able to have valid references to those.
Representative Quam.
Thank you, Madam Chair. Looking at the data that's there, I have some concerns, and frankly, offline, I'd like to see the some confirmation. I have no problem with moving this forward. I would have a problem for final passage if I didn't have confirmation of the strength of the system we're trying to implement.
Mr. Scandret.
Yeah, Madam Chair and Representative Quam, we can first provide you with the report. Those pages came out that's about this thick, and it has the methodology and more detailed information. But also Minnesota Community Measurement, who's our private agency that does the measurement, does this all in close consultation with providers as well as the researchers, and they can tell you the details of how the methodology's been developed. And you can understand that physicians and clinics aren't going to be very comfortable with this being reported until they've been very well tested, and that's in fact why we have the piloting language in here about let's try it first, make sure the methodology is fair before we do any public reporting on that. But we'll follow up with you for sure to provide those details.
Members, any other questions? Representative Schultz.
Thank you, Madam Chair. Would it be prudent to look at other demographic data like gender or sexual preference? I know the LGBT community was hoping that they could look at things like suicidal tendencies or mental health problems by those demographic and social indicators, or there's a variation in how we treat based on gender or sexual preference.
Mr. Scandret.
Yeah, Madam Chair and Representative Schultz. Yes, I mean, that's an important issue, and that's why we have language in there that makes that a possibility. Now, we already have enough data from other sources to know about the racial and ethnic disparities. There's data also that's available on some other groups, but what we wanted to set this up for is let's be sure that we know that there's a direct correlation in the data between the quality score and that particular characteristic, and that's why this part of it takes a little longer to develop, but it's still heading towards the idea, and I'm not going to say which things would be the logical ones, because that'll be driven by the data, But the idea of that language is that if there are other factors that are equally, important to and are affecting quality in that way, that there will be a process with stakeholder input in developing that and looking at the data before that would be implemented. So that would be like 2 years out before those things would be coming on board.
So,
Representative Schultz.
Madam Chair, so you wouldn't need our legislative approval to look at other factors? We're giving you authority in this bill to do that.
Madam,
Representative Zerwas.
Madam Chair, members, in my reading of it, it would be to take, so if they wouldn't be able to collect any new data, but breaking up data and analyzing data and recategorizing data in a different form would be allowed in this. It would not be allow for additional collection of data.
Thank you.
Members, any other questions? Seeing none, Representative Zerwas will renew his motion that House File 1208 as amended be re-referred to the Committee on Civil Law and Data Practices. All those in favor say aye. Aye. Those opposed, no. The motion prevails.
Thank you, Madam Chair. Thank you, members.
Thank you, Representative Zerwas. And members, if it's okay with the members, we are going to take one bill out of order, and that is Representative Baker's bill, House File 604, just due to some out-of-town testifiers that are going to need to get on the road. So Representative Baker is going to move that House File 604 be re-referred to the Committee on Health and Human Services Finance. And I'm not aware of any amendments, Representative Baker, so if that is in fact the case, to-year bill.
Thank you, Madam Chair. Actually, we do have an amendment. I think it was in front of everybody or included in the packet. It should be listed as an A15-0165.
I stand corrected,
All right, thank you
Representative
very
Baker.
much.
The members should have that amendment in their packet.
And if we could maybe make a motion to move that to my preference to kind of really structure the bill like I would like it. It's just from the department, just to clarify some dates and reasonable timelines.
Okay, so members, we will move the A15-0165 amendment to get the bill in the order that the author would like it. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Representative Baker, to-year bill as amended.
Thank you, Madam Chair and members of the Health and Human Services Policy Committee. I stand in front of you today that I carry what I consider the most important chemical dependency bill that I will certainly carry, and I hope that we take this one very seriously this year. In the last 17 years or so, chemical dependency has not really seen any kind of an increase in funding for the support of folks suffering from a disease. And I know that our state resources are limited. I know that we are really trying to do some good work this year in this session with some priorities, whether it be long-term care, whether it be medical assistance support, but that's exactly what this is doing for folks suffering from the disease called addiction. And unfortunately, my personal story is one of we didn't understand it until you walk that journey. And like many families, when you suffer diabetes or cancer or a severe brain trauma injury, you don't know what it's like until you're there. So my message really is simply this bill is asking for a 10% increase, and I'm hoping at the end of this session, at the end of the day, we will be able to find some significant dollars that recognizes this is a mental illness, and it has to be treated as such. No different than depression, no different than other major diseases. You don't have a problem finding a bed if you have cancer that all of a sudden your doctor tells you on a Friday. You're typically in the hospital the next day or that Monday if it's severe enough. It's not the case when it comes to a patient or a loved one who is finally at a place where they admit they are sick. And if they aren't ready to be sick, there's nowhere to go. But we are having a real bed problem and a bed shortage in Minnesota. And I can tell you firsthand that when our son reached that point that he said, "Dad, I'm sick," and when you call and there's nowhere to take him, you are in a terrible position because then you're in a holding pattern. And sometimes you can't hold them long enough until there's a ready bed available. We became very accustomed to Project Turnabout in our area and the good work that they're doing. And so, again, with that, I want to say that this is about a disease. This isn't about telling somebody just quit taking those pills or quit drinking that liquor. This is different, and there's something physically and mentally affected by people that do this. So again, nobody wakes up wanting to be an addict. And we had to learn the hard way and the tough love and not that understanding. And my message here today is to try to have as many people understand that's what this is. It is a disease. And if anybody tells you they are just failing morally, please tell them to come and talk to me. I'd love to have a conversation because this is a lot more than that. And the second part of my bill is we're looking at better ways to measure our successes in addiction. There are a lot of really good stories. They're not all tragic, and they're not always a revolving door. So if you would entertain us for just a tiny minute, I have a testifier here today that I have become close with and very appreciative of their hard work. And Madam Chair, I turn it over to Mr. Mike Schicks.
Welcome to our committee. Please introduce yourself and proceed.
My name is Mike Schicks. Madam Chairwoman, I'm the Director of Project Turnabout, which I'll talk about a little bit. Thank you so much to you and the committee for allowing me to Representative Baker. This isn't my comfort area. I have been in the field of treating addiction for 35 years, 25 at Hazleton, the last 10 of which you had through 2005 as Executive Vice President over all their treatment programs. Today, the last 9 years at Project Turnabout, a 122-bed rural program with 90% of our population coming from rural areas, only 10% from metro. We treat all 50 of all of the counties, and we kind of the best kept secret. What I will tell you is it's hard. And I'll tell you the reason for that is the stigma associated with it. All you see is the headlines. The headlines of the person that failed, the headlines of the person that didn't recover. I'm passionate about this. I'm more comfortable working in, as I said, in a treatment center with other people who need recovery. I've been in recovery from alcohol, methadone, and cocaine for 38 years myself. That's what got me into this field, certainly, and got me to go to school and to learn what I needed to learn about this illness. The last years, it's work with less, work with less, work with less. Put in an electronic medical record system. Have a better group of team members to address this. And we work and work and work. But the fact of the matter is, whether it's the stigma or for whatever reason, substance abuse, chemical dependency, which is a major factor in emergency room admissions, imprisonment, courts, gets the last, sometimes the last corner in terms of involvement. We all know part of it is because addicts, when they're using, don't behave well. But I'm here to tell you, in all of my years with Hazleton and here, I have seen, yes, I've been aware, I've read the papers about the tragedies, but I've seen the recovering construction workers, and I've seen the recovering celebrities that you don't see. And the reason you don't see them is because they're anonymous, and part of that anonymous has to do with the stigma. When I work with an addict, you know how to make an addict cry? You look them in the eye and tell them, I am worth it. You need to learn that you are worth it, because they don't know that. And in the rural areas where we can't recruit people, we have to put an intern up, pay for the intern's motel and room and board so that we can get them to come out and see what a magnificent program we have. So 10%, now my concern about this is the last time we got any kind of percent, it just stayed there. It was kind of like, okay, we got them taken care of for the next 10 years. But we have to give our staff top rates for intensive residential treatment, and I'm talking about 70% unemployment, 50% in my patient population have mental health issues, 50% have medical issues. $248 a day. What's a hotel cost? What does 3 meals cost? Round-the-clock nursing, what does that cost? What does 7-to-1 counselors cost? We turned away 1,700 people in the last 2 years, 90 in the last month. We had to build. Why did we have to build? Because we were at the top. We're not flush. I've got one administrative assistant in the entire project Turnabout. 3 people do all the finances. All of our money is in clinical services. So excuse me for sounding extremely passionate, but I am. They're worth it. They thrive. People in recovery thrive. You don't see it. So, yeah, I'm imploring you to support this bill. This is a great step. But more than that, we got to start waking up to the fact that this permeates people's lives in courts and healthcare and everywhere. And start to recognize that you're going to have a savings. It's pay now or pay later, because they're worth it. Thank you.
Thank you, Mr. Chicks. And then do you have another testifier as well?
Yes.
All right, so we have Heidi Kammer from March. Welcome to our committee.
Thank you, Madam Chair and members. My name is Heidi Kammer. I'm the Vice President of Chemical and Mental Health Care with Resource, and I'm honored to be here today representing a statewide constituency known as the Fair Reimbursement and Outcomes Group. I'm a board member with MARCH, the Minnesota Association of Resources for Recovery and Chemical Health, as well as the Minnesota Association of Treatment Directors. And on behalf of our statewide coalition, we fully support and urge you to move forward House File 604. Our constituency represents 350 providers of treatment and recovery services across our state. In addition, we are a vibrant workforce of 20,000 licensed professionals and recovery paraprofessionals across the state delivering high-quality care. And even more importantly, we together as a coalition serve and provide treatment to over 50,000 individuals and families each year. Most importantly, I would like to advocate for the 750,000 families across our state, which is 1 out of 3 families, 1 out of 3 constituents in each of our districts across the state who are impacted by substance abuse, chemical dependency, or addiction. As we talked about earlier, if you have any other major healthcare issues such as diabetes, heart disease, or cancer, you have about a 90% chance of accessing the needed care for your healthcare issue. However, if you have a chemical dependency or an addiction issue, you have about a 10% chance of accessing care. That is why this bill is so integral. Treatment works and recovery is possible. As Representative Baker said, our bill does indeed seek a rate increase and provides for outcome measures. I understand that this committee is focused on the outcome language of our bill. We are committed as a coalition across the state to ensure that our outcome measures do indeed demonstrate a return on investment, as well as demonstrate treatment efficacy. We would like to build upon the current statewide system known as the DANES, Drug Abuse and Alcohol Normative Evaluation System. It's a mouthful, I'm sorry, DANES, and NOM system to enhance this system. The research backs us up. The research indicates that for every dollar we invest in substance abuse treatment and recovery services, there's a $12 return. That $12 return is met and achieved through reduced healthcare costs, decreased emergency room visits, decreased incarceration and criminal justice costs, and other public healthcare costs. In closing, our constituency fully advocates for House File 604 in support of Representative Baker. The heart of this bill is health and wellness for individuals and families across our state. Treatment works and recovery is possible. Thank you.
Thank you so much for being here. Is there anyone else in the audience who wants to testify for or against the bill? Seeing, we have one more person. Feel free to come forward. Welcome to the committee. If you could just introduce yourself and give us your testimony.
Hi, my name is Felicia Ferrara. I don't know why I want to cry right now because I support this bill because I attend Resource and I've been an addict since I was 15 and I'm 29 and I couldn't do it without Resource, so I really support this bill. Thank you.
Thank you so much for being here and being willing to share your story. Members, are there any questions for the author or any of the testifiers? Representative Liebling.
Thank you, Representative Baker, and thank you to the testifiers. I mean, the young lady that just came forward, I can't see you now, but thanks for coming forward. It's hard to do, and And, you know, don't be embarrassed, because a lot of people cry in this committee. Sometimes even the members. Sometimes the members, sometimes the testifiers. So, but I do have some questions about the bill, but I just want to preface that by saying that it's wonderful that you all came, and I think it's so important that we keep saying in the legislature that this is not a moral failing. It is an illness. It's an illness that impacts our state tremendously, and we just need to keep working on it so hard on all fronts. And I have been really happy to see that we've made some progress in this. And I want to just get a little handle on what the bill is really doing, Representative Baker. So first of all, and I know some of this will be in the Finance Committee, and the kind of the heart of the bill is the increase in the rates. So, you know, maybe we don't want to get too far into that piece, but I just want to understand a little bit. First of all, I thought that we had something going on right now to develop outcome measures or some kind of quality process going on. Don't we have anything like that already? Do we really need this Section 2 report and all that? I mean, I'm kind of astounded that we don't have anything already going.
Representative Baker.
Thank you, Madam Chairman, and Representative Liebling, that's an excellent question, and one that I asked before I was, well, wait a minute now, we must have some kind of studies. What is going on now is the actual facilities and the providers are providing information on the incoming level of a patient or a person in need, and then when they leave, did they complete the treatment? Where are they going now to a halfway? But it ends there. The problem is that we're not following longer term. So I think what the intent of this study now is to follow this story and this journey longer than we are now. So we're really just seeing the income and the output from that time that they're in the treatment facility. This actually extends that much further, and again, maybe you want to comment on that if I got that right, but to me it's about taking the next 6 months or 2 years. And part of what got me excited about this study was because of the work that Resource is doing. Their outcomes have been exceptionally well done. They've got a training program, they've got job workforce issues going on, and again, there's a lot of folks right here with Resource today with us that I have seen firsthand that they are not just after the treatment and into a halfway home, but these folks are actually working with them to get them to be productive citizens again. And that's what they need. They need time to get themselves established with a job. And I cannot tell you that I've seen a better program with Resource because they do the aftercare better than most. And so maybe you want to just briefly comment on that too.
Ms. Kammer.
Madam Chair and members, so currently there is a statewide evaluation system for evaluation of chemical dependency treatment known as the DANES, the Drugs and Alcohol Abuse Normative Evaluation System, DANES, and this is a statewide system that measures our efficacy. However, as Representative Baker indicated, it is more of a pre-test, post-test, and we believe that with any rate increase, we need to represent that the outcomes are more than an episodic outcome, but they have a long-term impact. And so our hope is to work with the Department of Human Services, as we've met with them earlier this week, as well as other key stakeholders to identify those more longitudinal measures. And there are some systems that are in place with DHS that may have that potential, one being called POMS and another one I think called CHATS, but the department could speak more thoroughly to that.
Okay.
Representative Liebling.
Thank you, Representative, Madam Chair. And yeah, well, if we don't have this long-term thing going on, I'm with you, Representative Baker. I think that's critical to have that, because even though I know that the providers are underpaid, we do spend a lot of money on this. It's a critical area for services, and to not have outcome, not to understand which programs actually and what methods actually get better long-term outcomes than others is positively ridiculous. So we've got to be doing this, and so thank you for bringing this to our attention. I have other questions kind of about how the funding stuff works, and I'm thinking that maybe because of the jurisdiction of this committee, I'll either speak to you offline, Representative Baker, or bring them up in the Finance Committee, because I assume this has to go to Finance, right?
Yep.
So I think we could leave it there. Thank you very much. Thank you again for bringing this. I think we should, this is just the least we should do. We've got lots of other fronts in this war. And you know, I hope that we can, I'm glad to know that you're really interested in this, Representative Baker, and, you know, there's a lot going on here, and we've got to keep on working on it. Thank you.
Thank you, Representative Liebling. Members, I don't see any other questions at this time, so Representative Baker will renew his motion that House File 604, as amended, be re-referred to the Committee on Health and Human Services Finance. All those in favor, say aye.
Aye.
Those opposed, no. The motion prevails. Thank you, Representative Baker.
Thank you, Madam Chair and committee. Thank you very much. All right. Thank you. You bet.
Our next bill is House File 1272. And Representative Mack, if you'd like to move your bill.
Thank you, Madam Chair. Madam Chair and members, I would like to move that House File 1272 be re-referred to the Committee on Civil Law.
And go ahead.
Oh, and Madam Chair, I was also just going to mention that we do have a DE1 amendment that I would like to move in order to have the bill in the order that we would like to discuss it.
Wonderful. Any discussion on the amendment? All those in favor say aye. Aye. Opposed, motion prevails, and the amendment is adopted. Into your bill.
Thank you, Madam Chair and members. Members, this bill was brought forth to me by waivered service providers, and what we're trying to do in this is just basically some cleanup language, make some things more clear in law. I will let the experts go into the details of what this bill, does and help with questions, but basically, members, the first section of the bill deals with correction orders and conditional licenses. When there's a provider that maybe has had something happen at one of their sites that would merit having correction orders or a sanction, that it is site specific, so that that sanction doesn't necessarily go across the entire scope of their business and affect all of their sites. And again, there are people here who can build more on why that's important. And then the second part of the bill, Section 2, deals with settlement agreements. And this is basically just trying to make sure that providers are aware of settlement as an option versus pursuing going to court, and things of that nature can be very expensive, both for the state and the provider, in wanting to make sure that there's more awareness about settlement. So with that, Madam Chair, would like to turn that over to testifiers to kind of build on where this bill is coming from.
Welcome to our committee. Please introduce yourself and proceed.
Thank you, Madam Chair. Thank you, committee members. I'm Barb Turner. I'm the Chief Operating Officer at ARM. ARM is a provider organization representing about 150 providers of services to people with disabilities. The bill, the language that we're presenting today is doing two things, so I'll talk about them separately. In the first piece, with the implementation of 245D, which are the standards that now cover the majority of waivered services, that is a statewide license. And in essence, with some of the language that is in place, there's the potential without this clarification that if someone had a citation on that license because of an issue at one facility, potentially that could have covered their whole business. And there's some things sometimes, if you run into conditional licensing situations, where you have to have a high standard of not repeating and not doing the same thing. And potentially without this language that says the citation and sanction is specific to the site or service, unless there's some evidence that it's a widespread issue, obviously. But otherwise, the citation is specific to the site or service where the issue had occurred. And that's really the department has been operating in that manner, but this language will clarify that that's the intent. And the second part of the bill has to do with settlement hearings. And currently, There has always been the opportunity for providers to have some discussion with the department, but there hasn't been a real clear understanding of what that process might be, or even knowledge amongst many providers that that might be an option. And so oftentimes if people receive sanctions or fines for some sort of licensing violation, they would simply accept what they were given rather than going through a hearing process to appeal it, because the hearing process is very expensive and most often involves lawyers and time. And it's expensive not only for providers, but it's expensive for the department also. Mm-hmm. And so we work with the department to have language that lays out settlement as an option. So a provider could request, once a finding was made, a provider could request a meeting with the department, and it would hopefully be a more informal process, potentially not involve lawyers, and have some agreement. The intent for us and for the department is to have people be compliant with the rules, and simply charging a lot of money to people isn't necessarily the way to do that, but sitting down and having understanding of what they need to do and how they need to do things to make it better is a better option. And so that's what this bill is intended to do.
Thank you. And you have no further testifiers. Is there anyone from the audience that would like to test for or against this bill? Do we have any member questions or concerns? Representative Liebling.
Thank you, Madam Chair. Is this bill going, where is this bill going now?
This is going to civil law and data practices.
Okay. All right. That's good. Thank you.
Thank you. All right. Seeing no further questions, Representative Mack renews her motion that House File 1272, as amended, be re-referred to the Committee on Civil Law and Data Practices. All those in favor say aye. Aye. Opposed say no. Motion prevails, and you're on your way to your next committee. And I understand you have another bill, Representative Mack, which is House File 1303.
Thank you, Madam Chair. I would like to move House File 1303 be re-referred to the Committee on Commerce. And do not have any amendments, Madam Chair. And so I'll just give a brief introduction. Members, this bill was brought to me by the Minnesota Medical Group Management Association, which I have visited with several times over the past couple of years. And I actually have one of the member clinics, the Apple Valley Medical Center in my district, which serves thousands of people in the south of the river with their medical needs. And during these conversations, I've learned of some of the frustrations that have come with some of these small providers and contracts with the plans when it comes to being notified about changes to their contracts, amendments to their contracts, things of that nature, and how it affects these providers in a very real way when it comes to budgeting and making decisions on their ability to continue to participate in things of that nature. And so while this committee continues to work to improve transparency in the healthcare system, I believe that this bill tries to get at that goal. And I've introduced this bill in the past, and am pleased to say that I do know that there's been a lot of progress between the MMGMA and the plans and these providers in terms of addressing some of these issues, but this bill really gets at trying to make sure that we provide more time between notification that the plans give to the providers for their planning and budgeting purposes. So with that, I'd like to turn it over to the testifiers.
Thank you. Welcome. Please introduce yourself for the record and proceed.
Thank you, Madam Chair and members. My name is Nancy Haas with Messerly and Kramer, here on behalf on MMGMA, and I'm actually standing in for Mike Foley, who is the clinic administrator in Apple Valley, who had to run to a meeting at United Hospital just now. So I'm just going to introduce really quickly the Minnesota Medical Group Management Association, MMGMA. Has nearly 500 members across the state of Minnesota. The membership is, the profile of the membership is generally clinic administrators who perform managerial duties involving multiple areas of administrative tasks or direct patient care, along with significant managerial and administrative tasks. The MMGMA's legislative focus has always centered around advancing the concept of group practice within the health delivery system. This session, MMGMA's legislative priority centers around helping ensure more transparency in the healthcare workplace and ease of administration and coordination with the health plans. This work has brought forward House File 1303, which, as Representative Mack noted, seeks to ensure that changes to contracts through amendments or contract fee schedules are provided in enough time for our members to understand their content and have meaningful discussions with health plans prior to the deadlines or prior to agreeing with contracts. We are extremely thankful to Representative Mack for her authorship of the bill, both this year and in previous years. And through her leadership, we have been able to have meaningful conversations and discussions with the health plans about the challenges we face. Specifically, Catherine Commit from the Minnesota Council of Health Plans has met with our group on several occasions to help us understand the problems we are having and to try to make progress in addressing them. So at this time, I'm going to turn it over to one of our members, Jim Ryman, to share a few examples of some of the challenges we face.
Thank you. Welcome, Mr. Ryman. Please introduce yourself for our record and proceed.
Yes, my name is Jim Ryman, and thank you, Madam Chair and members of the committee for hearing the testimony. The reason you're looking at the day change that we're talking about from 45 days to 165 days, and I want you to be sensitive why this is an important and necessary change that we need to make. Right now, when we're negotiating with the health plans, if you look at a calendar year, which begins January 1st, if we start November 15th and we don't come to agreement by January 1st, the clinic is in a situation where they either have to term their contract, and in that case, then a notice is sent to the state for 120 days to let the state know we'll no longer be in network. This puts the clinic in a really bad situation, as you can imagine, because we end up looking like the bad guy on this. So if we back this up, if we say we have the 45 days to negotiate, 125 days to then notify the state, that puts us in a situation where we would have enough time to negotiate as well as notify everybody in the state that we're not part of that network. Now, when you buy a product from a health plan, how would you like it on January 1st if you found out that the physician you wanted in that network was termed out of the network? That's a heck of a time to find out. This would at least give you notice before you purchase that policy or that product that the physician that you thought was in network is in network. So I think it's a very important change to make for everybody that's involved. Another area that we're getting into right now with the health plans is that they're changing policies or procedures halfway through the year. When we only get a 45-day notice, a lot of times we're not finding out until the EOB comes across our desk and we found out, hey, we're not getting paid for a service anymore. When that happens, of course, there's a lot of frustration because we've budgeted for the whole year to get that service rendered and paid for. So it's very difficult on the provider group when they're not getting paid for that. Lastly, I just want to make the point that this 165 days we're asking for, it's no different than the state gives us when they change a policy, when they change their fee schedule, as well as Medicare. When Medicare changes them on January 1st, we're notified in August what those changes are going to be. It gives everybody enough time to really go through a thorough analysis and understand the reimbursement ramifications of something like this. So I ask you to make this change, this important change, because not only does it help the clinics, but it also helps anyone purchasing a product in the state of Minnesota of knowing who's in network and who's out of network. And with all the changes we have going on right now with healthcare, the last thing we need to know is not knowing who's in network when you purchase a product.
Thank you. Is there anyone else that would like to testify on this bill? Are there any member questions? Representative Liebling.
Thanks, Madam Chair. I wonder if DHS has a comment on this.
Is there anyone from the Department of Human Services? All right, gotta take her. Welcome.
Welcome. Thank you. Matt Burdick from DHS. I'm actually from a different part of the agency. We don't have anyone here today that can comment on it, but we'll follow up and get back to the committee.
Thank you.
Okay, well, Madam Chair, if I, maybe Representative Mack, you don't know whether DHS has any comment, or have you talked with them about the bill?
Thank you, Madam Chair and Representative Liebling. I have not, and I don't mean to assume they're fine with it by any means. From my experience around here, usually with bills like this, they do get a hold of you if they have major concerns. But I will be certain to follow up with them, following this hearing and just seeing. But they have not reached out to me at this point to express any concerns or problems with it.
Representative Liebling?
Well, thank you, Madam Chair. And Representative Mack, I just feel kind of like at a loss with this bill. I don't really, I hear the, I mean, the testifiers made a lot of sense, but it just makes me wonder why it was set at 45 in the first place. And, I mean, it's what a difference we're making here. It's not like you're giving them 15 more days, it's a big, big difference. Do you know why it was originally only 45 and it just, huge change, it seems
Yeah.
like.
I think I can explain that a little bit.
Madam Chair, I'll defer to the testifier at this point.
Thanks.
Yeah, we actually, when we first passed this, we had it at 165 days. And it was moved to 45 days because it was kind of the plans, and it was kind of like something we worked out between the clinics and the plans, because the plan said 165 was too much notification that they would have to give on any kind of change, and that they would have a difficulty with that. I can tell you right now, half the plans in the state would not have an issue with this at all. The other half might, because again, depending if you want to use this for leverage in a negotiation, you wait until the last minute to negotiate something like this. But for the most part, that's the history on this. It was 165. We moved it down to 45 as kind of a middle ground, and let's see how it was going to work. And as I'm testifying now, it isn't working.
And Madam
Representative
Chair,
Mack.
Madam Chair, and to that concern, following this hearing in terms of what that right number might be, if 45 is very difficult on the one end, 165 is difficult, I would be happy to follow up with the department, and then also continue to work with the groups on this particular issue and see if 165 is very difficult for 50% of the plans, obviously we'd have some work to do on that specific number. The goal being that we're just trying to make sure that the plans are providing enough notice so that the providers can be nimble and serve their consumers well.
Okay, thank
Representative
you.
Liebling? Okay. All right, seeing no further questions or concerns, I will renew the motion that House File 1303 be re-referred to the Committee on Commerce and Regulatory Reform. All those in favor say aye. Aye. Opposed say no. Motion prevails, and you're on your way to Commerce.
Okay, members, moving right along, we have House File 981, Representative Peterson. And so Representative Peterson will move that House File 981 be re-referred to the Committee on Government Operations and Elections. We have the bill before us, and there is an author's amendment, the A2 amendment. Is that correct, Representative Peterson?
Yes, if we could move that, it's a technical amendment to just clean up some of the language, and so we can get the bill in the form that we'd like.
Okay, so members, Representative Peterson moves the A2 amendment. All those in favor say aye.
Aye.
All those opposed, no. The motion prevails. Representative Peterson, to your bill as amended.
Thank you, Madam Chair. This bill is really just related to optometrists. I know that there was some doctors and chiropractors in the initial part, but this bill does really just relate to the optometrists, so that's really what we are talking about in this particular bill. And this has been vetted out through lots of different organizations, as well as also the sister bill that's going through the Senate as well. So it's mostly related to operations and things of that nature. However, I will refer to my testifier here, who would be happy to give more details on the bill.
Thank you. If you could introduce yourself for the record and proceed with your testimony.
Good afternoon, Madam Chair and members of the committee. I'm Randy Snyder, the Executive Director for the Minnesota Board of Optometry, and we'll shorten this down to a quick response. There are 7 board members that have worked on this for the last 2 years, and we thank Representative Peterson for bringing it forward. We spent many committee hours working with the provider associations, and it's slightly amended from last year, still remains non-controversial. House File 981 is a technical amendment without opposition at this time. 3 distinct sections. Section 1, lines 11 to 533 are very specific to board operations. This is education that was required in a 5-year rollover from 2008 to 2013. The certification requirements are now passed. We have met that statute, and so that needs to be removed from language to make our Practice Act contemporary. Part 2 of the fees, this is line 6.2 to 6.15. We have not raised fees since 1984, so a significant period of time. That is correct, 1984. I don't get to say that often. But we are also codifying those now in statute and removing those from rules. The fees were also included in the governor's budget and has already been, a testimony been provided in front of Representative Dean's Health and Human Services Finance Committee. So those are essentially the two pieces that there are no issues to at all. Part 3 is the section on discipline, and again, we don't believe that there are any issues there. This was meant to provide a clear direction to our core mission of public protection, which is what the board is charged to do. Originally, per the suggestion of the Attorney General, we mirrored the existing Board of Medical Practice grounds for discipline. So we took those laws that have already been vetted, have been thoroughly debated, and it was recommended from them that instead of revising or tweaking outdated, ineffective language, that we look at those and make them consistent to our vocabulary and to our operations as optometrists around the state. There are 1,076 optometrists as of today in this state. Our current language works, but we believe that this gives more specific issues and seems more transparent. It also mirrors common practices with other boards that are health-related licensing boards, and it has been thoroughly vetted before the legislature in the past. We appreciate the author's amendments. There were some suggested minor language tweaks, which we support. The Minnesota Board of Optometry further eliminated all the temporary suspension, the emergency suspension, and the felony level sexual criminal conduct language. And that was in the separate bill that you heard earlier this morning, House File 1584 from, if you remember, the Board of Medical Practice and Board of Nursing presented that. So we've removed all of that language also out of this bill. It's a clean bill. We know of no opposition. We really need to move this forward in this session, so we thank you for the opportunity to bring it forward to you. It outdates some obsolete language, provides us flexibility with fees, and makes more for contemporary practice standards. And thank you, Representative Peterson, for serving as the author, and to the members of the committee, I will stand for questions.
Thank you. And is there anyone else in the audience who would like to testify for or against this bill? And seeing no one, members, are there any questions? Representative Liebling.
Madam Chair, I always have questions.
We appreciate it, Representative Liebling.
Thank you, sure. Thank you. Well, thank you, and I know we talked about this, and I had reviewed this extensively, and I'm okay with most of it, but I hadn't seen really hadn't had a chance to go through the final bill as it ended up after our conversation, and there was a part in here that I know a lot of the health-related boards have this language about being able to get access to a licensee's medical and mental health records. Is that still in here? I was trying to page through, and I thought that you had left that in.
Mr. Snyder?
Madam Chair, Representative Liebling, I'm not so sure that that was in there. I believe that we tried to strike everything out that was a concern for you. That would not be important to us, so we would easily amend that if that was an issue for you, Representative Liebling.
Okay.
Representative Liebling?
Madam Chair, thank you very much, and I appreciate that. And we, as I said, we had a really good conversation, and because I was pretty familiar with these whole issues because I had carried a bill for the Board of Pharmacy, and in fact, in that Board of Pharmacy bill, we did not allow them to have that language, as I recall. I'm looking at Ms. Aves. So actually, Ms. Aves looks like she has a comment on this. We worked on this extensively.
Ms. Aves.
Madam Chair and members, the language I believe Representative Liebling is looking for is on page 11, line 26, mental examination and access to medical data. It is in the bill.
Okay.
Representative Liebling.
Okay, thank you, Madam Chair. Well, I'd like to really direct members' attention to this, if I could, because this is language that when I was carrying the bill for the Board of Pharmacy, I had discovered this in there, and I know that it is kind of boilerplate for a lot of the boards, and so it is in some of the boards' language. But I consider this, and thank you for your willingness to take this out, Mr. Snyder, but I consider this really, really intrusive language that we've just sort of allowed to be in here as boilerplate, and this basically allows, there's a place in here, I'm not seeing it exactly right now, but it basically says that somebody who's got a license to be a professional is really consenting to having their medical and mental health records open to the board if the board decides it wants to see them. And, you know, I could agree that a person could even be required, if the board has sufficient cause, say that to believe that a person has a serious disability that's preventing them from practicing safely, I could see giving the board authority to say to somebody, if you want to keep your license, you got to go and get an exam and let us see the results of that exam. That seems reasonable. But to just say that we get to look at your medical records and your mental health records seems a bridge too far to me. And Ms. Aves, I'm still not really, as I'm looking at this now on the fly, I'm not really seeing exactly that language, but I did see it before.
Miss Aves, and I think if I understood, because Representative Liebling, I was following along, it's on 11.26.
The subdivision,
bill?
Madam Chair and members.
Ms. Aves.
The subdivision begins on 11.26, and it allows the board to direct a person for a mental and physical examination if they have probable cause to believe the person has a mental health issue, a substance abuse issue, or a physical infirmity that causes them to be unable to practice safely. On the following page, beginning on line 12.16, it says that under those same circumstances, the board can have access without the person's permission to medical data and health records relating to that illness, that reason for possible disciplinary action. So it's conditional upon the illness or infirmity of the person, but it does allow unfettered access.
Representative Peterson.
We just realized that the A1 amendment, which would have struck all that language, was apparently not, I don't know, somehow the memo was missed or something like that. But we do have an A1 amendment that struck all that language out of there. And so I'm not sure what the best process would be, but it is from the revisor's office, et cetera, and I'm not sure exactly how it.
So well, I guess first I'll just, Representative Liebling, is this as you read through what Ms. Aves just walked us through, is that what you were referring to?
Madam Chair, I believe it is. Yeah, I believe it is. It's this language that really says that if you're licensed, your medical records are an open book to the board. And gosh, I think that's a lot to ask.
Madam Chair, all of those were...
Mr. Snyder.
I'm sorry, Madam Chair. All of those were included in that A1 amendment.
So if maybe Representative Peterson, because I would imagine if we're just striking out some subdivisions of the bill, that would be technical in nature, and we could do that here. If you could walk us through, what does that A1, what does it strike? If you could walk us through that, and we can see if it's the will of the committee to go that direction.
Okay, so page 8, line 4, delete everything after the word disease. Okay, so page 8, line 4, delete everything after the word disease. Then also page 8, line 5, delete everything before the semicolon. So page 8, line 5, delete everything before the semicolon. Page 9, line 23, delete everything after the word patient. Page 9, line 23, delete everything after the word patient. Page 9, line 24, delete everything before the semicolon. So page 9, line 24, delete everything before the semicolon. Page 9, delete lines 26 to 36. Page 9, delete lines 26 to 36. Page 10, delete lines 1 to 36. Page 10, delete lines 1 to 36. Page 11, delete lines 1 to 36. Page 11, delete lines 1 to 36. Page 12, delete lines 1 to 19. Page 12, delete lines 1 to 19. And page 13, line 3, delete the word health professional and insert the word optometrist. And also on page 13, line 3, delete the word health professional and insert the word optometrist. And also on page 13, lines 23, 29, and 34, after the word faith, insert and in the exercise of reasonable care. So line 13, or page 13, lines 23, 29, and 34, after the word faith, insert and in the exercise of reasonable care. Madam Chair.
Oh, okay. So as we walk through that amendment, members, that's a lot of changes to the bill. And I'm not sure I'm comfortable
And we can
putting all of those in at this point. I'm very sensitive to your concern, Representative Liebling. And I maybe thought the A1 was just dealing with that one section you were talking about. Clearly it was longer and maybe very necessary cleanup, but I can't say I'm comfortable with putting that kind of I think we went beyond a technical amendment at that point. And so we're heading to government operations next. So I would understand that a lot of this could be handled and would be in the scope of the Government Operations Committee. And so I would request that it certainly gets cleaned up at that point. Representative Liebling, do you have any thoughts? Or if you would just maybe like to do the technical and strike those lines that you referred to, that's a bit more straightforward and easy to follow for the committee in terms of what you're trying to accomplish. Representative Liebling.
Well, Madam Chair, thank you. And as we were sitting here, I hadn't realized that what Representative Peterson just went through is indeed a lot of stuff that we had kind of agreed on, and I didn't realize that it was still in the bill. So I'm totally with her on the amendment she just went through, and it's just a goof up that it didn't get here. And I am a little concerned with having this done in the GovOps committee because I really think this is all healthcare stuff that we're talking about, and I'm worried that that committee wouldn't get it. I mean, these issues, if anybody had a question about it, they're not really issues that could be vetted very well in that committee. So, and I understand the chair's reluctance too, because it is a lot, even though, I totally understand what she's doing, because this is all stuff that we talked about and that I'm really familiar with from other health boards. So I don't know. I think it would be preferable to me, and I don't know. I know we're on short timelines here, Representative Peterson, but I would sure like to put on this amendment before it moves to the next committee and have it then be, I'm just worried that it'll cause a lot of heartburn in the next committee because people will be like, what the heck's going on here?
And Representative Liebling, I certainly believe that we want to get this and make it sure it's vetted appropriately. I will say in terms of within the scope of HHS, this will also be going to the HHS Finance Committee, which I know you also sit on, and so can make sure that we catch all this, that it's all the way that we're comfortable with, that you're comfortable with. I would love to keep it moving with deadlines coming, knowing it's coming to another HHS committee. So if we could have a commitment from Representative Peterson to make sure that those changes get in place, keep moving today, and when we see it again in HHS Finance, verify that it's all been taken care of. Representative Liebling.
Thank you. Well, Madam Chair, thank you. That would be fine. That would be fine. And I would just really suggest saving that amendment for the HHS committee because for what reason I said, but I had another question too, and that is on the A2 that we adopted. Because when I'm looking at the A2, I see that what it's doing is adding sections to the repealer. So that amendment's, yeah, Ms. Aves looks like she's ready to explain what we're doing here. That'd be great.
Ms. Aves.
Madam Chair and representatives, this is a situation similar to last week where the reviser struck certain subdivisions. The language is in the bill, but did not add them to the repealer, and for purposes of tracking repeal of sections, they need to be named in the repealer.
Thank you, thank you.
Okay, members, any further questions? Seeing none at this point, thank you for your work, Representative Peterson, and commitment to keep working on it. I will renew my motion that House File 981 as amended be re-referred to the Committee on Government Operations and Elections. All those in favor say aye. Aye. Those opposed, no. Motion prevails. Thank you, Representative Peterson. And we have another bill from Representative Peterson, House File 1193. And Representative Peterson will move that House File 1193 be sent to the General Register. And we have the bill before us, and Representative Peterson, I understand that you have an A1 amendment.
Yes, and I guess this is the theme of the day today. After speaking with the Department of Human Services in regards to the A1 amendment, they felt that it would be better to address it in a different fashion. And so in order to I have a technical oral amendment, and if I could change in reference to not adopting the A1 amendment, but add to my oral amendment to address what we're trying to do in the A1 amendment, I'm wondering if that would be possible.
So, Ms. Peterson, you want to just withdraw the A1 amendment?
Correct.
And instead make a small technical amendment, oral amendment to your bill?
Correct.
To accomplish the same goal according to the department?
Yes.
Okay, so members, we're just withdrawing the A1 amendment, so you can disregard that. And Representative Peterson, what is the oral amendment you want to make to your bill?
So in order to accomplish the goal of the A1 amendment, on page 3, line 26, after the word Minnesota, add or another state. So for example, the Salvation Army is not incorporated in the state of Minnesota, but it does qualify under all the rest of the information that is on line 26 on page 3. So I would just say that they could be incorporated in another state as well and still comply with all those other things in order for them to also be a part of this bill.
Okay, so members, just to restate briefly what the oral amendment is, it is on line 3.26, after the word Minnesota, insert or another state. So all those in favor of that amendment signify by saying aye. Aye. Those opposed, no. The motion prevails.
Okay.
Representative Peterson, to your bill as amended.
Well, I maybe messed up this too, because I do have another technical amendment that also needs to be addressed, and this is to align with the sister bill that's going through the Senate. They recognized that they needed to add 2 effective dates after 2 other sections so that it's consistent. And I don't know if, and I maybe should have done that in one motion, but you guys can decide whether or not you would like, how you want to address this. But after page 4, after line 11, insert the words, or insert effective date, period. This section is effective July 1, 2015. And also on page 4, after line 17, insert effective date. This section is effective July 1st, 2015. So in essence, the line on 4.20 would also be after those 2 other sections, so that would be consistent.
Okay. Members, are there any questions?
I have one.
Okay. Excuse me, Representative Dean.
Thank you, Madam Chair and Representative Peterson. Just the reason for the change is, will this line up exactly with the Senate language then? Is that what you're trying to do?
Yes.
Representative Peterson?
Yes.
Okay.
Representative Dean?
Thanks.
So members, is everybody clear on that technical amendment? Okay, all those in favor signify by saying aye. Aye. Those opposed, no. The motion prevails. Representative Peterson, 2-year bill as amended.
Thank you, Madam Chair and members, and thank you for being tolerant. This bill is actually in works of talking about licensure, and it began with work that was done in 2012, and we are still tweaking this as we move forward. So we're looking for time to find the exemptions for the after-school programs, and really this is what this bill addresses. And it was developed jointly with the Department of Human Services, and I do have a testifier here that can speak more to the bill, but it basically exempts after-school programs from school-age chair licensing and repeals a moratorium on school-age child care licensing that expires in July.
Thank you for being here. Welcome to the committee. If you could introduce yourself and proceed with your testimony.
Good afternoon, Madam Chair and members of the committee. My name is Carrie Dennison-Kaneen, and I am the Executive Director of Ignite After School. We are Minnesota's statewide after-school network, and so a little bit about who we are. We, as a network, bring together the various stakeholders and providers who provide after-school and summer learning opportunities for young people. So that includes places like parks and recreation, community education, schools, boys and girls clubs, YMCAs, and other nonprofits that provide after-school programming. We are in support of this bill because we are looking particularly at after-school youth development programs that serve only school-aged youth, so K through 12, that are providing after-school youth development opportunities for young people that are not structured or operating in a child care framework, and many of them would not be able to operate or provide their services to families or young people if they had to be licensed as child care. So we worked in partnership with DHS to come up with language that would still ensure that these programs have safety policies in place and all of those pieces. And so some of those components in the bill, you will see that the bill exempts after-school programs from school-aged care licensing. It does repeal the moratorium that's been in place while we had time to address this issue. And to be eligible for the exemption, a program must be operated by a nonprofit serving youth in kindergarten through grade 12. They must provide structured youth development activities that take place when school is not in session. They must have a director or supervisor on site who's responsible for the program and is overseeing policies that ensure safety. They also have to obtain written consent from a parent or guardian for the young people who are participating, and they also have to provide written notice to the parents or guardians that the program is not licensed or supervised by the state of Minnesota and that is not eligible to receive child care assistance payments. Thank you, Madam Chair.
Thank you for the explanation of the bill. Is there anyone else who wants to testify for or against the bill? Okay, seeing no one. Members, any questions? Representative Schultz.
Thank you, Madam Chair. On page 3, lines 30 and 31, can you explain exempt? A program exempt under this clause is not eligible for child care assistance under Chapter 119B.
Madam Chair and Representative, I will do my best there. So in our work at Ignite After School, this issue came to us because there are a lot of after-school programs out there that don't identify as child care. They don't, and as we worked with those programs that don't currently receive child care assistance, they felt like this, was fine. And as we worked with DHS, in order to receive child care assistance, really wanting to make sure that if you're receiving child care assistance that you are following child care licensing requirements, but these programs are after-school programs, they don't really consider themselves to be child care, and therefore felt comfortable with the exclusion from child care assistance.
So if
Representative Schultz.
Thank you, Madam Chair. So if a low-income family wanted to go to our program in Duluth, is called Key Zone After School, would that program fall under this clause and not be eligible for income assistance to pay for that program?
Ms. Dennison, could you say your last name again? I'm sorry.
Canine.
Canine.
Yes, yes.
Ms. Canine.
Madam Chair and Representative, this exemption in no way prohibits any program from seeking childcare licensure and getting childcare licensure and then therefore being able to have childcare assistance. So they could choose to fall under this exemption if they don't want to be licensed, or they could be licensed and receive childcare assistance.
Representative Schultz.
Thank you, Madam Chair. So are the typical programs after school that are in a public school, do they have licensure requirements?
Yeah.
Ms. Kunian.
Madam Chair and Representative, if you look at the other exemptions here, you will see that school-aged care that is operated by a school is exempt from licensing already in another exemption.
Thank you.
Members, other questions? Representative Quam.
Thank you, Madam Chair. With that oral amendment, and I tried to get attention to ask this question before that passed, when you open it up to any state, do we have an idea of how many different organizations that might fall into that? There being, quite a few states out there.
Just one moment. Representative Quam. Welcome to the committee. If you could introduce yourself.
Thank you, Madam Chair. Madam Chair, Representative Quam, members, my name is Doug Franz, and I'm representing the Salvation Army. The legal name of the Salvation Army is the Salvation Army in Illinois Corporation. It's just how our organization is. We're similarly situated to the folks you're helping here. And to the precise question, in our conversations, at least with DHS here, the issue is that it be a non-profit organization, a legitimate not-for-profit corporation somewhere, that it not just be Doug calling himself a nonprofit. That's the key issue, and to recognize a legal filing in another state, I still believe will still accomplish that public policy goal. And frankly, it's a pretty easy piece if there's any question to go on any state's corporate statutes to get the filing to the Secretary of State for everyone to verify that it is indeed a legitimate not-for-profit. And I will testify, Madam Chair, that the Salvation Army is a legitimate not-for-profit.
Representative Quam.
That wasn't, he answered a question I wasn't asking. I was asking, do we have an idea of how many different organizations across the 50 states might qualify on here, because you're not referencing any definition of what a nonprofit is. And looking at this and having lived in a couple other states for a period of time, I'm aware of there being organizations in those states that are nonprofit and recognized. So it seems very broad and open-ended to me, and I'd like some comfort.
We'll go to our next testifier, and just as I'm reading this, I think the clarification that the amendment was trying to make was that if the nonprofit is operating in Minnesota, we're just saying that they have to be that they can be incorporated in Minnesota, or they can be incorporated in another state, but operating as a nonprofit here in Minnesota. But I could turn it over to our testifier for further clarification. Representative Quam.
Thank you, Madam Chair. That seemed to me as intuitively obvious. So I will endeavor to get clarification on the scope that this opens us up to.
If you could introduce yourself and proceed.
Madam Chair, members of the committee, Regina Wagner with the Department of Human Services in the Licensing Division. We did provide technical assistance to Ignite after school on this language. Representative Quam, to your specific question, I think the answer is we don't know. As you can see, the initial language was crafted to say operated by a nonprofit incorporated Minnesota. Salvation Army became aware that they wouldn't fit that. They were looking at a different place in statute to try and put an exemption. We might have been a little less comfortable with that. They felt that if we broaden this language, they could actually fit much better in this scheme, and so we thought that made sense for both of us. But the pure answer is that we don't know how broad that would be. It is certainly possible that child care centers that are operating now may be incorporated in other states, and but authorized and operating here in Minnesota, so I couldn't tell you the answer to your question.
Representative Quam?
I'll pursue this offline.
Representative Liebling?
Thank you, Madam Chair. Since you're the testifiers at the table, I guess I'd just like to know, you said you provided technical assistance. Does DHS have a position on the bill?
We are not opposing the bill. I think from DHS's perspective, we would take a close look at anything that looks like an exemption from licensing. As we engaged with Ignite After School, what we began to understand was sort of a growing programming in other states around out-of-school time, in particular, serving a much broader range of youth than our licensing statutes would govern, up through K through 12 instead of through age 13. I will say, and we did discuss this with Ignite After School, that in other states we are seeing alternative regulatory schemes emerge that are far more substantial than this, but we felt that these hit upon some very key pieces if they were trying to move this forward, and we were certainly much more comfortable with these kind of points in place than a simple exclusion. We did not think that that was going to be quite as helpful. From licensing's perspective, what's very important, and to some extent what sort of spurred this a couple of years ago, is if we are out at a location, either because we get a call from somebody that they think someone's not licensed, or maybe it's contiguous to a facility that we are looking at, it's important for us to be able to determine, you know, do you need a license? Should you be operating under a license? We felt that these key points here would allow us to be able to recognize when someone is operating more as an out-of-school time program and would truly be exempt from licensure. That's another reason why, and also with mindful of our program integrity hat through the Office of Inspector General, why not having CCAP, allowance for CCAP. I mean, if you want to get child care assistance program, then clearly you're looking more like child care, and we think, you know, Ignite After School said that's not the group that we're talking about. So we did certainly have language in here, in Representative's bill, that allows a program like this to get licensure. There's no attempt to exclude that. Again, it gives a little bit of, I guess, flexibility if you're operating within the world of the child care assistance program. Getting licensure would make sense, but what we heard from Ignite After School is that the core of their membership is not that, and we thought that that was supported by what we were seeing in some other states.
Representative Liebling.
Thank you, Madam Chair. And one other question is, does the background screening, do background screening requirements apply if they are exempted from licensure?
Ms. Wagner.
Madam Chair, Representative Liebling, no. No, there are no formal licensure requirements as part of this, which I think is why you see some language around ensuring that parents have some notification, and also ensuring that the program has some policy around supervision of staff and volunteers.
Thank you.
Okay, members, seeing no further discussion, Representative Peterson will renew her motion that House File 1193 be referred to the General Register. All those in favor signify by saying aye.
Aye.
Those opposed, no.
No.
The motion prevails. Thank you, Representative Peterson. The next bill is Representative Pierson's bill, House File 1637. And Representative Pierson will move that his bill, House File 1637, be re-referred to the Committee on Health and Human Services Finance. And we have the bill before us. I'm not aware of any amendments. Is that accurate, Representative Pierson?
That's correct.
Okay, so Representative Pierson, to your bill.
Yes, thank you, Madam Chair. Members of the committee, thank you for the opportunity to present House File 1637. This bill establishes a supplementary group residential housing rate for the Silver Creek Corner Supportive Housing Unit in Rochester to bridge a funding gap for facility operations. Silver Creek Corner provides supportive housing to late-stage chronic alcoholics with round-the-clock staffing and support. This facility opened in December of 2011 and has documented success in reducing costs associated with public intoxication, including an overall reduction in detox admissions, jail stays, inappropriate emergency room usage, and abusive use of the judicial system. Silver Creek Corner is operated by Center City Housing, a group that runs similar supportive housing units in Duluth and St. Cloud. This bill will bring the group residential housing rate for the Silver Creek Corner facility in Rochester in line with the rates currently in place at the facilities in Duluth and St. Cloud. I, earlier this year, did have the opportunity, along with Representative Liebling, to tour this facility. It's a fantastic service to the community, and in frustrated testimony from those who have dealt with the chronic alcoholics in our region, these folks really need this service and care. And I have with me Nancy Cashman from the Center City Housing, who can provide more information about the Rochester facility and the benefit it provides to the local community.
Thank you for being here and welcome to the committee. If you could introduce yourself and proceed with your testimony.
Great. Thank you. Good afternoon, Madam Chairwoman and committee members. My name is Nancy Cashman, and I am the Supportive Housing Development Director for Center City Housing. I want to thank you for this opportunity to talk to you today about our Silver Creek Corner program. Silver Creek Corner is a permanent supportive housing program that's located in Rochester, serving 40 long-term homeless, chronic alcoholic single men and women. This project is modeled after the New San Marco in Duluth and Rivercrest in St. Cloud. Silver Creek Corner serves a very specific group of people who have struggled with having any long-term housing stability. They may have had short episodes of housing and short episodes of sobriety, but very little long-term stability. As their inability to stop drinking grows, their housing success usually decreases. Often, if they have housing, they lose it because of non-payment of rent, behavior of guests, and often issues with disturbing the neighbors. Most residents at Silver Creek meet the Minnesota definition of long-term homeless, meaning that they've had multiple episodes of homelessness or at least a year continuously on the street. And most of the residents prior to moving in have had an average of 5 years of continuously living on the streets in Rochester prior to entering the program. In addition to struggling with alcoholism, almost 80% of the residents at any given time also have co-occurring disorders. Also, in addition to their homelessness, our residents have often overused very expensive systems like detox, jail, police time, and emergency room. Many current residents have had over 20 treatment attempts and hundreds of detox admissions prior to entry into our programs. Traditional treatment options have not been very successful for this group of people who end up living on our streets, primarily because of the consequences of their alcohol use. Silver Creek Corner operates as a housing first model and does not require abstinence to maintain housing. The point of engagement with the residents is around housing, not around their alcohol use. The goal of the program is to achieve safe, permanent housing. Harm reduction strategies are used to reduce the risks and harms associated with alcohol use and abuse, including homelessness. Other services offered at Silver Creek Corner include nutritious meals and snacks, medication safekeeping, health monitoring, information and education, money management, sober activities, advocacy, access to addiction treatment services, and access to mental health services. We also enroll folks in mental health plans and help them access primary medical care. There's sobriety supports, including FDA-approved drugs such as naltrexone, and palliative care, and sadly, end-of-life care. This program offers 24-hour services to tenants, and it is staffed by a site director, case manager, nurse, kitchen staff, programming staff, front desk staff that offers security and support to the tenants. There's always a minimum of 2 staff on site 24 hours a day. Since opening in 2011, we've had tremendous success at stably housing this very difficult to house population. The current residents right now have an average of 678 days of housing stability, with 50% of those folks having almost 3 or more than 3 years of housing stability. We have also reduced detox admissions by 90% as compared to prior to entering the program. Periodically, people do need to use detox for medical reasons. Also, police contacts have been reduced by 85%, and we get a lot of positive reaction from both the sheriff and the police department in Rochester. Basically, the police no longer need to drive these folks out to the detox center, which is quite a distance, and they're able to use their time even more appropriately. Every resident is connected to a primary physician within 60 days of moving into the program, and this has really resulted in that decrease in emergency room usage. It's difficult for us to get specific data on that because of HIPAA laws, but we do continue to hear anecdotally from hospitals that they are seeing our folks much, much less in the emergency rooms. So our goal with this legislation is to increase the GRH service rate for Silver Creek Corner so that it is the same rate as the other two programs we manage. There is no difference in the services provided at Silver Creek Corner, and this adjustment would really help deal with our funding gap. So I want to thank you for your time and your consideration of our program, and if you have any questions, I'd be happy to answer them.
Thank you. And is there anyone else from the audience who wants to testify for or against the bill? Seeing no one. Members, any questions? Representative Liebling.
Well, Madam Chair, thank you. I have to comment on this because, you know, Representative Pierson and I went and visited the facility, and of course, I think I had some minor role in getting it started in the first place in Rochester. And just building on the hearing that we had on Representative Baker's bill earlier, you know, there's not all one solution for the problem of addiction. And so this is for people who are, you know, chronic. These are for the most serious people that we used to just give up on. And what this shows is that there's a model out there that really can work, can really reduce harm, and very importantly, saves a lot of money that otherwise goes to kind of this cycle of detox, emergency room. And so this is something that really works. It's not for everybody. I know sometimes there's some people have consternation around the fact that it doesn't require sobriety, but we've learned that if you have that as a barrier, that it basically leaves a certain group of folks without any hope. And so this is a great model. I appreciate that Representative Pierson was willing to bring the bill forward, and I hope we'll be able to fund it. And it is funded, I think, at this higher level in these other locations, if I'm not mistaken. So we're not asking for something special here. We're just asking for the same level of funding that is being given in the other locations and is shown to be very successful and very cost effective. So thank you.
Members, any further questions? Seeing none, Representative Pierson will renew his motion that House File 1637 be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Pierson. Members, our next bill up is House File 1036. Representative Baker. And Representative Baker will move that House File 1036 be sent to the General Register. And there is an author's amendment, I understand, the A1.
Yes.
Representative Baker, you'd like to move the A1 amendment to get the bill in the order that you would like to discuss it?
Yes, Madam Chair.
Okay, so members, all those in favor of the A1 amendment, please signify by saying aye. Aye. All those opposed, no. The motion prevails. Representative Baker, two-year bill as amended.
Thank you, Madam Chair and Committee. We're here to talk about the Minnesota Academy of the Physician Assistants. And this bill was brought to my attention that really over the years, the physician's assistant is becoming a much greater and high-quality need in Minnesota and for the services of health in our state. And over the years, things have changed, and we need to make some modifications to really make it much more efficient for larger organizations to be able to operate more efficiently. And I think today's bill really provides a lot of good housekeeping issues. This should be a non-controversial bill. We have not seen any opponents to this bill. It is also being carried on the Senate side by Senator Eaton and co-authored there by Senators Laurie and Clausen. And again, I appreciate other committee members that have co-authored with this on it today. So today I just want to turn it over to Ms. Becky Ness, who's the legislative chair of the Academy of Physician Assistants, and she will take it over from here. So, Madam Chair.
Thank you. Welcome to the committee, and introduce yourself and proceed with your testimony.
Thank you, Madam Chair and Representative Baker. My name is Becky Ness. I'm the Legislative Chair for the Minnesota Academy of Physician Assistants. I'm a licensed physician assistant. I practice internal medicine and nephrology for the Mayo Clinic Health System in Mankato. I appreciate the opportunity to testify today. Madam Chair and members, the A1 amendment modifies existing reporting requirements by physician assistants to their licensing board, the Board of Medical Practice. Currently, PAs must notify the board in writing prior to beginning practice with the location of that practice, who their supervising physician is, and what their prescriptive practice is. PAs are the only licensed healthcare professionals in Minnesota that must file this information with their licensure board. The board keeps this list in an attempt to kind of keep a file of who the authorized prescribers are in case they have questions from a pharmacy, or if a prescriptive practice would be brought into question. They can pull this document and be able to track where the PA works and what their prescriptive authority is. Initially, we had wanted to eliminate the notice of intent to practice, but once it was brought to our attention by the Board of Medical Practice how they actually used the document, we were willing to work with them. And so this amendment, instead of striking that subdivision, simply amends it to change the name to practice location notification and to change the timing of submission from prior to the onset of practice to within 30 business days of a PA starting with a new practice, changing their practice location, their supervising physician, or something within their prescriptive scope of practice. When we brought these changes to the Board of Medicine, they were agreeable with those changes. They didn't offer any other concern. And the document, now called Practice Location Notification, will continue to be used by the board to maintain a database of PA prescribers and their locations, as well as what prescriptive practice they have been delegated.
That's the A1.
Thank you for being, oh, wonderful. So that's just the amendment, and then to the, did you want to continue to the rest of the bill?
If I would, please, Madam Chair.
Yes, go
Thank
ahead.
you. Like I'd said before, now with the issues being addressed in the A1 amendment, the Board of Medical Practice is now neutral on the bill, and we haven't heard any opposition from other medical groups. The first piece of this bill deals with the supervision of PAs. PAs in the state of Minnesota do not have independent practice authority. We have a written practice agreement with the supervising physician that outlines what our scope of practice as well as our prescriptive practice will be. This bill does not change that. Minnesota PAs strongly believe the collaborative partnership between the PA and their supervising physician works well, and we want to maintain that type of practice. Current law, however, requires a PA to maintain a list of alternate supervising physicians. The purpose of this list is to keep a record of those physicians who may be working with the PA in the absence of their primary supervising physician. When this was initially enacted, there were very small practices, 1 or 2 physicians, 1 PA. That's not how the PA practice is today. A lot of outpatient care is delivered in large multi-specialty clinics with dozens or even hundreds of physicians on staff rotating amongst the PAs within the department. PAs who practice in hospital ERs or surgical suites can work with a dozen or more physicians on any given shift. What this bill does is it removes the language from legislation and places it back at the practice level, allowing the PA and the physician and the organization to determine how to accurately document and assign that relationship. Section 2 of the bill is a policy issue. Under current law, a physician may have supervising agreements with up to but no more than 5 PAs. This was an arbitrarily decided number. This bill removes that ratio from legislation, placing that decision back at the practice level. Working in rural Minnesota, I can give an example of in our southwest region, there was a small clinic who had 2 physicians and 6 or 8 PAs. One of those physicians left. That then left 1 physician over the amount of supervision with this 5-to-1 ratio, and it was a scramble within the health system to try and adjust the collaborative or the supervisory agreements and to make sure that no one physician within the organization had more than 5 PAs. We feel that taking this out of legislation and putting it back at the practice level will help ease some of that. There are 11 states that have eliminated this cap, including North Dakota. South Dakota is considering it. Of the 11 states who have removed this cap, none have brought it back into the legislation. The removal of this ratio is supported on a national level by the American Medical Associates, the American Academy of Family Physicians, the American College of Surgeons, and the Federation of State Medical Boards. And at a recent primary care summit just held on February 28th with members of the Minnesota chapter of the American College of Physicians, the Minnesota chapter of the American College of Pediatrics, and the Minnesota Academy of Family Physicians, when this legislative agenda was broached, there was not opposition raised specifically to this point, but rather a request that we work with the Board of Medicine on how this monitoring would take place if it was removed from legislation and put back at the practice level. And we've opened those discussions with the Board of Medical Practice on that issue. I think that hit everything.
I think so.
So, thank you, Madam Chair and members, for your attention. And if any questions have risen, I would be happy to try and answer those for you.
Thank you for being here. And I'll just ask quick, is there anyone else who wants to testify for or against the bill? I don't see anyone. Members, questions? Representative Schultz.
Thank you, Madam Chair. Can you just describe what's involved in the supervision and whether, it might be wise for us to put language in this bill or a future bill to describe what's involved when one supervises a PA, and if 5 was arbitrary, is it wise just to eliminate that?
Ms. Ness or Representative Baker.
I'll take a stab at this, Madam Chair, if I could, and to Representative Schultz's question. A lot of questions that I asked when they brought this to me. So the number 5 is a number, and again, that was a number that was used many years ago in the smaller practices typically. And so I said, well, what about 20, 100? I mean, what level is a safe number for that? Because I was really not even sure about using an unlimited number, but I think what it does is, in this case, is it puts it back to the practicing facility and clinic. If a clinic thinks a doc is safe with a medical doctor having 10 physician assistants underneath that license, that should be fine. I think that clinic should make that determination. Some doctors should be given more authority than others. And each doctor gives each PA a level of room to practice. So not all PAs are going to get the same ability to do all those things. I think that doctor determines that. And if the clinic thinks that a doctor should be given, again, 10 or 20 based on what they feel is safe and properly supervised, I think then we're letting that up to the local clinic to decide that number. I think what I hear is 5 is just too small. And I think we should allow that number to be expanded. Other states do the unlimited number at this point, and it seems to be successful. So I think for that reason, that's where that number came from. And again, each doctor has to determine what ability and what parameters that they will allow that PA to work under their direction, given those parameters. So each doctor sets that up.
Representative Schultz.
Thank you. The first part of my question, though, what is involved in the supervision typically?
Ms. Ness.
Representative Schultz, the degree of supervision is really determined on the skill set of the physician as well as the skill set of the PA. A brand new graduate PA, for instance, working with a physician, their scope of practice or the amount of supervision they need would be much more concentrated, and they'd have a smaller scope of practice than a PA who has been working for 10, 15, or 20 years. So in terms of supervision, that can look varied depending on the practice. The practice that I work in is an outpatient clinic practice in internal medicine, and I also do outpatient, inpatient, and dialysis unit nephrology. The amount of supervision that I have is predominantly on paper, and my physicians being available by phone, walking down the hallway and talking to them, asking them to come into the room with the patient if I have questions about what I'm seeing, what I'm hearing, or what I'm not hearing and I think I should be. We have a brand new provider starting in the clinic. That provider will have a limited number of patients that she sees on a daily basis. She will have a more closely follow up with discussions and case reviews with the physicians within the practice until they're comfortable with her skill set and she's comfortable with the expectations of the providers. Did that answer your question?
Representative Schultz.
Thank you, Madam Chair. So it sounds like if you're a supervising physician, you might only want a few new PAs and maybe some senior. You don't want all new PAs under you because then your workload is substantially more. Does that sound right?
Ms. Ness.
Representative Schultz, I can't speak from the physician perspective because I am not one. But yes, routinely in a lot of practices, most of the physicians prefer a combination of new grads with more seasoned and experienced PAs, partly because it helps offset their workload, but then those of us who do have that experience can help guide and mentor that new graduate as well.
Representative Schultz.
Thank you, Madam Chair. So maybe you'd want to think about language in this bill, looking at the ratio of seasoned PAs to new PAs under their guidance.
Representative Baker.
Madam Chair, and Representative Schultz, I think that our intent here is to allow that clinic to decide what is that doctor's either capacity or that practicing physician knows his or her level of what they want to carry. Again, sort of going back to the philosophy of maybe more local control is better, is sort of the intent of this bill. So without trying to create more ratios of new PAs and seasoned PAs and what does that mean and how many years is that, I think we're trying to keep it simple, and by doing that allows less paperwork, less, and hopefully less paperwork, more time with the patient, I think is the intent of this bill. Representative Schultz.
Thank you.
Representative Schultz.
Thank you, Representative Baker. Madam Chair, I guess I just worry because I worry about outcomes of care and quality of care, and we have many nurses who are worried about the number of nurses per patient being cared for, and if we let it all be local, we might get in trouble with outcomes and liability and expense. So I guess those are just some of my concerns.
Representative Liebling.
Yeah, thanks, Madam Chair. First of all, I think PAs are terrific, wonderful. My son is going to marry one, which I'm very happy about. Yeah. And I also have had concerns with just this part of the bill. The rest of it I really have gotten to be comfortable with. And I really do hear you. I think you've made a very good case for why we shouldn't have an artificial ratio in law. And I also, Representative Baker, I understand what you're saying. I think you're right about that. The only reason I raised my hand was really to sort of say that I'm glad to hear that you're working with the Board of Medical Practice about this, because the thing that gives me a little worry is kind of what happened with the APRNs, and I realize that PAs and APRNs are very different, but we started to hear from APRNs, and part of the push for their independence was they said, yeah, we're supposed to be supervised, but it's not real supervision. And so that's what really gives me pause, is that if it's just open, most physicians, I think, will take their responsibility very seriously and supervise to the degree that it's needed. But I just hope that we can kind of work out what it means to be supervised, so that we don't just end up with a situation where where PAs aren't getting supervision that they really do need, because sometimes the problem is that you don't realize what you need, or you may, is to not realize when something isn't the usual case. And that may be the rare occasion. It probably is the rare occasion, because I know that PAs can become extraordinarily competent at what they're doing, especially when they focus in certain area of practice, and I have no concerns about that. But just as time goes on, I just hope we can kind of watch where this goes to make sure that we maintain that team approach that really is best for everybody and really allows the PAs to continue learning and continue extending their competency, and also kind of keeps the physicians on the hook to really do the real supervision that they've committed themselves to doing. So thank you. I'm going to support the bill.
Any other questions or comments, members? Seeing none, Representative Baker will renew his motion that House File 1036 be re-referred to the General Register. All those in favor, please say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Baker.
Thank you, Madam Chair and Committee.
Okay, members, we are getting close. Our next bill is House File 1011, Representative Albright. And Representative Albright will move that House File HF1011 be sent to the general register. And I don't see any amendments, Representative Albright, so to your bill.
Madam Chair, I do have an oral amendment.
Okay, Representative Albright, state your oral amendment.
Thank you, Madam Chair. It pertains to line 1.17.
Okay,
And the oral amendment is to delete, that includes mental health, and insert the words in the.
okay, so members,
On line same, there's a, after the word treatment, include the words or add the words of mental health.
okay, so members, looks like just reordering the sentence a bit. So on line 1.17 of the bill, strike the words that includes mental health and insert the words in the. And then again on line 1.17, right after the word treatment, insert the words of mental health.
That is correct, Madam Chair.
Okay, members, all those in favor of the amendment, please say aye. Aye. Those opposed, no. The motion prevails. Representative Albright, to your bill as amended.
Thank you, Madam Chair. I'll be brief in my remarks. Maybe I should just stop there. Please. The language that's been requested and has been in front of you has been requested by the Department of Health, Department of Human Services, to clarify the understanding in terms of the meaning of the number of hours that a PA would be required of in order to provide service to those that are most vulnerable amongst us in terms of psychiatric care. And I do have two testifiers, Madam Chair, and I think for the sake of brevity and other reasons, I'll let their professionalism speak to the bill as opposed to me.
Okay, so first we have Ms. Stark. If you could introduce yourself.
I'm actually Tracy Kaiser. I'm the physician assistant.
Oh, I apologize. Would you like to go first?
I certainly will.
Okay, if you could state your name and proceed with your testimony.
Yes, my name is Tracy Kaiser. I'm a physician assistant. Thank you, Madam Chair, and members of the opportunity to testify in support of House File 1011. So as a physician assistant, I'm here today on behalf of the Minnesota Academy of PAs, the professional association representing Minnesota's 1,800 PAs. I practice inpatient psychiatric medicine at Regents Hospital here in St. Paul. I'm here not from Regents, but as a PA practicing mental health. PAs are licensed healthcare professionals authorized by Minnesota state law to practice medicine with physician supervision. PAs may perform any service that a licensed physician has delegated to them, including diagnosing illnesses and the prescribing of medication. PA education is modeled on a physician education, and their grounding in team practice and ability to expand access in virtually any setting. So PAs provide healthcare services across the entire healthcare spectrum and with every age group. PAs provide and are reimbursed for care by all insurers in almost every setting. PAs are being reimbursed for evaluation and management services, for mental health diagnoses, for medical assistance enrollees, private insured and Medicare patients in inpatient mental health settings. In the outpatient mental health setting, currently PAs are being reimbursed by virtually all private payers and Medicare. However, there's one exception. PAs practicing in outpatient mental health settings are not being reimbursed for services by medical assistants for their enrollees. So what does it mean for you as policymakers? As many of you are well aware, there's a great need for psychiatric providers in the outpatient setting. Providers in mental health clinics are needed for obtaining, adjusting, and renewing prescriptions. Right now, in virtually all mental health clinics, there's a significant wait to be seen by a clinician for medication management, and there's a backlog of MA patients waiting for care. Medication monitoring and management is a key component of treating mental illness, but these medications must be adjusted and renewed based on individuals' and patients' needs. Waiting weeks or months for an appointment to get that adjustment is too long for a person diagnosed with severe mood, anxiety, substance abuse, or thought disorder. In addition to helping MA patients get more timely care that can prevent crisis and expensive readmissions, this bill has the potential for cost saving in the MA program, since MA reimburses at 90% of the physician rate. When a patient is seen by a PA, the cost for these services will be 10% less than what the Department of Human Services is paying now for a patient to visit a psychiatrist. So in 2012, Governor Dayton signed a bill allowing reimbursement for PAs serving MA patients in inpatient hospital settings. In the latter part of 2012 and early 2013, the Commissioner of Human Services gathered a group of mental health stakeholders to assist the Commissioner in developing recommendations on how to improve access to outpatient mental health services for medical assistants enrollees through the use of physician assistants. So during these conversations, there have been ideas proposed by some mental health stakeholders that go beyond the scope of expanding access and move into the areas of education and regulation of PAs. So these recommendations were not supported by the Board of Medical Practice or the Minnesota Psychiatric Society, as well as by the Minnesota Academy of Physician Assistants. They would make Minnesota an outlier among the 50 states and discourage, not encourage, PAs to serve MA patients. Given the severe shortage of psychiatrists in Minnesota that are able to serve MA patients, we believe it's important to look at ways to get these patients the care they need and are not now receiving on a timely basis. Our bill is asking to allow reimbursement for medical assistance for PAs for outpatient evaluation and management services in outpatient mental health clinics after a PA has completed 2,000 hours of clinical experience in the evaluation and treatment of mental health. So in conclusion, I hope that you will support our legislation. I would be happy to answer any questions that you have. Thank you.
Thank you so much for being here. Our next testifier, if you could introduce yourself and proceed.
Of course, Madam Chairman, committee members, I'm Dr. John Kuzma. I am an inpatient psychiatrist and the inpatient medical director at Regents Hospital. I am speaking here not as a representative of health partners, but rather as a clinician who has been working closely with PAs in a professional setting for the past 15 years. I fully support the proposed legislation, as Ms. Kaiser really outlined very clearly. I would just add one, in terms of realistically, as an inpatient psychiatrist, I am very aware of the shortage of psychiatrists and mental health professionals. And one of the points I think we need to be clear here is, without having the support of PAs, what is effectively happening is, in many cases, these psychiatric patients, often with very complicated illness, are being seen by a primary care provider. And in those primary care clinics, they may often being seen by a physician assistant. I would submit that certainly in a perfect world, we would have unlimited supplies of psychiatrists, but I'm afraid that's not the world, not the reality that we would have. I would say that in my experience in working with PAs, this is not merely a paper supervision, but it actually is, I found it to be a very powerful collaborative relationship, and they truly live up to the moniker of a physician extender. To me, the biggest advantage of allowing PAs, to see patients in a mental health setting is those patients can be seen in a mental health clinic. So that if there are patients that really are complicated or there are issues that are coming up, the physician assistant is then able to turn to a supervising psychiatrist in a setting, and allows for really more active management. And I think it's really, in terms of being a very effective way of trying to extend a very limited resource. Barring any questions, thank you.
And thank you for your testimony. Did you have something you wanted to add, Ms. Kaiser?
Thank you, Madam Chair. I just wanted to let you know that recently the Minnesota Academy of Physician Assistants met in a primary care summit. And the current American College of Physicians, the policy chair for the Minnesota chapter, was actually quite surprised at the fact that this was currently not in statute already.
Okay, members. Well, I guess first, anyone else in the audience wants to testify in favor or against this bill? You guys want to come forward? Introduce yourself and proceed with your testimony.
Committee Chair and members, my name is Dr. Tricia Stark. I have a PhD in clinical psychology, and I'm a licensed psychologist. I'm testifying on behalf of the Minnesota Psychological Association and the Mental Health Legislative Network, which is a consortium of some 30 advocacy and provider groups that work together on mental health issues. Physician assistants do play an important role in our healthcare system, and access to qualified professionals who can prescribe psychotropic medications is desperately needed, but this bill is not the answer to these access considerations. This bill would essentially allow physician assistants to practice as mental health professionals without the needed training. Mental health professionals, the provider group that provides for the assessment, diagnosis, and treatment of mental illness, have at least a 2-year master's degree solely in the study of mental health-related field and more than 4,000 hours of closely supervised practice following their academic training before they're able to be licensed. This bill would allow PAs to practice almost independently without the academic background or the supervised practice that most mental health professionals have. The Mental Health Legislative Network has been working on this issue with physician assistants for several years and haven't been able to reach a compromise on the additional training and supervision that would be required for PAs to safely practice in outpatient mental health settings with individuals covered by medical assistance who are likely to have serious and persistent mental illness. This bill would allow the least trained and supervised individuals to provide care to the sickest patients. People on MA have the more serious mental illnesses, so it's different than PA services being covered in primary care or for those patients with private plans. Because of these conflicts and the unwillingness of the physician assistants to consider the acquisition of additional academic and clinical training, the Mental Health Workforce Task Force did not include PAs in the plan that was developed because there was no agreement. This bill requires only 2,000 hours of supervised practice. That's a far cry from the 5,000 to 6,000 hours of supervised practice that most mental health professionals have received. PAs must decide if they want to be a specialist or a generalist. If they want to specialize in the diagnosis, assessment, and treatment of mental illness, they simply need more training. In lieu of traditional mental health training, physician assistants have a practice agreement with a supervising physician. This type of supervision is different from that experienced by mental health professionals who meet with a supervisor for 2 hours a week in order to be licensed. Being able to phone someone for input is not sufficient oversight to overcome the lack of training and supervision when in a crisis situation. We've offered a compromise, and they've said no to our compromise. And we would ask that you not support this bill that would allow unprepared providers to deliver mental health services to our most vulnerable population.
Thank you for being here. Ms. Abderholden.
Thank you, Madam Chair, members of the committee. Sue Abderholden, Executive Director of NAMI, Minnesota. I just want to point out a couple of things. This has been a multi-year issue that we've been working on. One of the things that I do want to point out that Ms. Stark did say, Dr. Stark said, is that people who are medical assistants are more likely to have the most serious and persistent mental illnesses. One of the ways you figure out what medication someone needs is actually by doing a diagnostic assessment, which it actually says that they're not able to do that. So medication management for an existing patient versus a new patient is actually a pretty big deal in our book. The other thing I want to mention is that Regents Hospital actually has a physician assistant training program that we've been very impressed with. It's a basically year-long. There's, a lot of, kind of classes in the sense that they take as a part of that. We had actually met with one of the psychiatrists and one of the physician assistants back in December and January to talk about could we create a compromise. And we've gone back and forth. We had added a little bit more, and we're actually willing to take that part off and to say that someone could complete a 12-month or longer postgraduate psychiatric training program like they have at Regents, along with earning some CME credits or 6-semester credits. So we're not asking for years and years of study, but I think when, again, you're talking about treating people with the most serious mental illnesses, asking for a few credits asking for a year-long program, I don't think is out of line. We also said if someone completed 2,000 hours of clinical experience being supervised by a psychiatrist and added a few more semester credits at that point, 12 semester credits, that we thought at least they would get some coursework in order to do this. We understand more than anyone about the impact of workforce shortages, but I don't think our choice should be someone who has not had very much training, frankly, dealing with folks and treating folks with very serious mental illnesses or none. I think that we need to keep building up the middle. And again, I don't think asking for some coursework along with supervised experience is out of line. And with that, I'll close my testimony.
Thank you. I don't see anyone else from the audience who wants to testify. Question, Representative? Oh, I'm sorry. I forgot. I will put you on the list, Representative Salvers. I do have Representative Baker first.
Thank you, Madam Chair. I'm not sure who would be the one to answer this. Maybe Dr. Stark, perhaps, or Ms. Epperdorn. As my first question was going to be before you even got here is, where did the 2,000 hours come from? If that was a number that's sort of kind of the same number for the primary care, and I'll let you answer that maybe first, and I'll follow up with another question if I could, Madam Chair.
Representative Albright.
Thank you, Madam Chair. I'm going to ask one of the previous testifiers to respond to that.
Ms. Kaiser.
Thank you. Thank you, Madam Chair. So the 2,000 hours is something very similar to what South Dakota has done to reimburse PAs for mental health care in South Dakota. It also is somewhat similarly related to a bill that was passed last year for APRNs, as they're working for independent practice to have 2,000 hours, 2,082, I believe it was. So similar to that. But please remember that after these 2,000 hours, we're still going to be working very closely with our supervising physicians.
Representative Baker.
Madam Chair, and maybe this is to Dr. Stark. Knowing how difficult it is to get full-blown doctors of psychiatry out in Minnesota, and maybe I'm thinking more in rural, I would think that if we have PAs out there with good training, not full-level docs, I guess my question is, isn't it better to still have somebody who's practicing under a doctor like yourself that accepts a PA, if you even would, maybe you wouldn't in this situation, but others that might say, you know what, I think this PA could really add a lot to our services and the help because we can reach more people. And I guess I wonder, isn't it better to have some people getting some treatment, and even if the PA has to call their supervising doc and say, hey, here's the situation, I'm looking at it, isn't that better than no treatment at all?
Ms. Starks.
Thank you. First, I would not be doing the supervision because I'm a psychologist and I'm not a physician, so I'm not licensed to do the supervision. I understand the argument of, you know, isn't something better than nothing, and I'm not sure that it is, because improper diagnosis and improper assessment with the wrong medications and the wrong treatment is very problematic. And diagnosis is complicated. And just being able to phone, sort of phone a friend doesn't do it, I don't think, in these situations. I understand that there's a real need for people who can prescribe, but I think we have to look to other kinds of situations like our crisis teams, behavioral health homes, and things like that to help with these functions.
Representative Baker.
And maybe just to follow up, and I thank you for that. I think my only thought would be I would really want to be able to trust then that chief doctor having a PA under their license to really give that PA the scope that they should be practicing under, similar to what I've learned, again, moving my bill forward, that some will have more parameters and some will have much less. So I would hope that supervising doctor would be confident that analysis and prescriptions and treatment would be quality and certainly not hurt anybody, because then that's going to jeopardize the doctor's license as well. So I only offer that up as a comment at the end. So thank you.
Representative Franzen.
Thank you, Madam Chair. Ms. Stark, does your network include organizations whose members are licensed to practice medicine?
Ms. Stark.
Sorry, Madam Chair. Yes, it does. It includes the Minnesota Psychiatric Society.
Representative Franson.
Thank you, Madam Chair. So I'm just wondering what brings you to testify on behalf of the network against the bill when network providers support the bill?
Ms. Stark.
Madam Chair, my understanding is I have no evidence that the Minnesota Psychiatric Society supports this bill. They're not here to testify, and they have not told me that. We've been working with them on a compromise for a number of years.
Representative Franson.
Thank you, Madam Chair. And Ms. Stark, the information that I have, they do support the bill.
Madam Chair,
Ms. Stark.
that's different than the information that I have.
Madam Chair.
Representative Albright.
Madam Chair, and for the benefit of the members in the packet with the bill itself, there is an outline of the organization supportive of the language. You might just avail the members to peruse that as we consider the legislation.
Okay, members, just if you want to take note that that is in your packet. If you don't have it, we can make sure to get it to you. Our next question, Representative Schultz.
Thank you, Madam Chair. So if we change that to medication maintenance, I mean, it sounds like they're doing medication management, and it's the evaluation piece that might be troublesome. But maybe I also want to know from the testifier, Ms. Kaiser, did you go through that program at Regions that was mentioned by the other testifier, and you're okay with you're supporting this bill, so are you okay with just clinical practice then?
Yeah.
Ms. Kaiser.
Yes, thank you, Madam Chair. Yes, indeed, I did go through this 12-month program, but I do want to say that Regents Hospital is one of 2 fellowship programs for PAs in the United States. And I don't believe that there's any way that all PAs who are interested in going into mental health would be able to go through this, as we're currently only admitting 1 PA per year to finish this.
Representative Schultz.
Thank you, Madam Chair, and thank you for that. And so would it be better if, I mean, I'm worried, like Representative Baker, that, you know, we have this backlog of patients on or receiving Medicaid coverage, and they're not getting care that they need. And that if they've been diagnosed by a practicing board-certified psychiatrist or other mental health provider, that this PA would just continue the medication they're currently on, assuming that they were given the right diagnosis. So would it appease NAMI, for instance, if they changed that to just doing medication maintenance rather than any type of new evaluation of patients?
Ms. Abderholden.
Thank you, Madam Chair, Representative. What we would really like to see is just a few more classes. You know, the 2,000 hours is about equivalent, as my understanding, to the 1-year program at Regions. So we're not saying it can only be the Regions program. We're okay with doing the 2,000. All we're asking for is an additional 25 Category 1 CME credits, or the equivalent 6 semester credits. I mean, again, I don't think that's a lot. If you do the 2,000 hours, then you would earn 50 CME 1 credits, or the equivalent of 12 semester credits. So we're just asking for some just additional education so that, you know, people know more when they're going to treat people with the most serious mental illnesses. So I don't think we're actually that far apart in what we're trying to move forward with.
Representative Schultz.
Thank you. And as a supporter of this bill, I would encourage the other authors to work and try to include that. It doesn't seem like it's too onerous, and maybe it could be concurrently while they're getting the clinical practice as well. Thank you.
Thank you, Representative Schultz. Representative Loeffler.
Well, thank you, Madam Chair. And I'm wondering, since it isn't defined what the clinical experience is, other than it's in the evaluation and treatment of mental health, whether there's a significant difference if someone were to do that clinical experience in an inpatient setting, which is what is currently allowed. To me, that's a very different setting with a different level of acuity. You've got different backup resources, different coaching, than if you were to do it in working with someone who traditionally practices in an outpatient setting. And I'm wondering if we need more definition around what that clinical experience is as well. And I'm not an expert on this, but I wonder if we could get some feedback on that.
Representative Albright?
Thank you, Madam Chair, and Representative Loeffler. I think the context that you're speaking to in House File 1011 found on point or line 1.15 when it speaks to and in outpatient settings.
Representative Loeffler?
Madam Chair and Representative Albright, this is changing where they can practice. But my question was about where the clinical experience would have to be and whether we should refine that the clinical experience is in an outpatient setting with the types of situations they would encounter there, as opposed to someone who did 2,000 hours in a crisis unit of a hospital that almost never saw anyone with lower level mental health needs.
Representative Albright?
Ms. Kaiser has a response.
Oh, excuse me, Ms. Kaiser.
Thank you, Madam Chair. And again, I mean, speaking of the training that I had was both an inpatient and outpatient that we have at Regions. But again, I wanted to make it inclusive of all areas of experience that you can get in psychiatry, whether you're getting your experience in outpatient mental health clinics, which many would, whether they're getting experience in inpatient psychiatric settings, emergency room psychiatric units. I wanted to make it inclusive and experience in all psychiatric settings where you could all get different kinds of psychiatric experience.
Representative Loeffler?
Well, thank you, Madam Chair. And I'm wondering if Ms. Abderholden might comment on that as well, as whether she feels there's a difference and maybe an advantage to having some more clarity there.
Ms. Abderholden?
Thank you, Madam Chair. Representative Loeffler. One of the reasons that, you know, we finally went along with them being able to use Medicaid in the inpatient hospital setting is because in an inpatient, you are much more like a team. You know, you are interacting all the time with the different professionals who are working on the ward. You're just doing a lot more of that. Whereas in private practice, unlike, you know, in family practice, the physicians usually go from room to room to room to room. In psychiatry, the psychiatrist sits in one room. They don't really go from room to room, and you don't have some of that, you know, kind of off-the-cuff conversations that you would normally have in a regular physician's office. And if you ever go to your family physician, and we have PAs in mine, you know, you see them talking in the hallway all the time. So it's a little bit different. So I do think it's a different type of training that you get in an inpatient hospital because, again, you're working with all those folks sometimes at the same time. But I also understand the need that if you went to a community mental health center, you might also see someone with, you know, very high needs, people with a very serious mental illness, unlike, you know, perhaps in a regular physician's clinic.
Well,
Representative Loeffler?
Thank you, Madam Chair. And, you know, I'll just say that as a lay legislator, the licensing bills to me are the most frustrating because we're asked to make choices about training levels at which people's lives are really at their most vulnerable and that can have serious consequences. And recently in the news has been a lot of articles about the evaluation that was being done by our University of Minnesota Medical School, and it's in a psychiatric research issue that ultimately involved a suicide of one of their patients. And these are trained psychiatrists. And we're asking to have someone with dramatically less training be given the authority and the right to help people who may be at all different levels. And I just really wish we had kind of levels of care so that the people with the most serious needs would always be referred to the people with the most serious credentials, because this bill seems to give them, you know, fairly broad authority. And some of the medications that have come out recently for people with mental health that work are almost guaranteed to give them diabetes and other chronic lifelong challenges. I mean, there's real ramifications that I'm hearing some patients are not being fully informed about, and they may have chosen not to take those medications if they'd realized what it did to the rest of their physical life. And so I just have a hesitancy, even though I don't have any good reasons to not support this, is just because I don't see sort of the kumbaya that we usually like to see on a licensing bill. So I'm confused yet, but just wanted to say that this is serious business, and would love to have the evaluation that Representative Schultz keeps asking for.
Madam Chair,
Representative Albright.
notwithstanding Representative Loeffler's just recent comments, this is not a licensing bill. This has to do with the scope of practice. And I certainly appreciate the comments made about the Kumbaya, peace in the valley. And certainly with respect to NAMI and respect to the other stakeholders of this, we are continuing the conversations. I'll leave it at that, but I believe Ms. Kaiser has some comments as well.
Ms. Kaiser.
Thank you. And again, this is not a licensing bill. This is allowing for something that we're already doing in the inpatient and outpatient settings. One thing I also wanted to add, if I can, is PAs as practicing in Minnesota and state statutes that you need to get 100 hours of CME every 2 years, and that's something that we've already been doing, and that's additional medical education that we already have been doing and need to do to continue our license here in Minnesota. Thank you.
Representative Zerwas.
Thank you, Madam Chair. I have some follow-up questions for Ms. Stark, if she can come back to the table.
Representative Zerwas.
Madam Chair, Ms. Stark, so it's my understanding that you're a psychiatrist, you're a psychologist, not a psychiatrist, correct?
Madam Chair, Representative,
Stark.
that's correct.
Okay, and I missed it when you were doing the introduction, I apologize. Did you say you're here representing the Minnesota Psychiatric Society?
Ms. Stark.
Madam Chair, I'm representing the Minnesota Psychological Association and the Mental Health Legislative Network, which is a consortium of 30 advocacy and provider groups of mental health services.
Representative Zerwas.
Okay, so you're not, I thought you had said that, is it the Minnesota Psychiatric Society, are they a part of one of those groups? Or, because you brought them up earlier and said that they opposed the bill?
Ms. Stark.
Madam Chair, I don't know where they stand on the bill. I know that they are part of our network and that our network is opposed to the bill.
Okay.
But
Madam Chair?
where they are, I don't know.
Representative Zerwas.
Well, I think we know, Madam Chair. On the list provided, we have Alina Health listed as a supporter, Hennepin County Medical Center listed as a supporter, Fairview Health Services listed as a supporter, Health East listed as a supporter, Essentia Health, Aver Health, North Memorial, Minnesota Academy of Physicians, Minnesota Hospital Association, the Minnesota Medical Association, the Minnesota Psychiatric Society, which you had mentioned previously, listed as a supporter, and the Service Employees International Union. So my question is to Ms. Stark.
I'm the co-chair of the network.
So my question is to Ms. Stark. Ms. Stark, do you still wish to assert that the Minnesota Psychiatric Society is opposed to this bill?
Ms. Stark.
Madam Chair, Representative, I cannot assert their position. What I can assert the position of the Mental Health Legislative Network. That's what I can assert.
Okay. Madam Chair.
Representative Zerwas.
I guess just a comment, and, I think what this legislation does is it talks about MA reimbursement for outpatient PAs doing mental health. It's a healthcare access bill. To be clear, PAs can get MA reimbursement for inpatient services, and mental health PAs practice for private pay patients, outpatient. So this idea that they're not qualified or they're going to get less service or less care, if you have private pay insurance, you can go to a PA for mental health services. That's what this bill is about. And so I want to be crystal clear with who really does support this bill and then who is opposing it. But members, the Minnesota Psychiatric Society, along with the MMA, along with the Hospital Association, along with private pay insurance companies, which already does reimbursement for outpatient PAs doing mental health services, they all support this bill. And so the reality is, members, this is a healthcare access issue, and the choice isn't a couple thousand more hours, and then they can get a PA, or that somehow MA patients are going to get a less quality care or service, because this is already being done for private pay. This is whether or not you're going to give MA patients access that they flat out likely won't otherwise get, or not. That's what this bill is about.
And Mr. Sposato.
Thank you, Madam Chairman. My name's Dominic Sposato. I represent the Minnesota Psychiatric Society, and I'm pleased to be here. After sitting through the hearings this morning, I finally get to come up and say something. I'm here just to clarify our position. The Psychiatric Society has a legislative committee that met last week, and we reviewed this legislation and decided to support it because we felt it was an equity issue related to payment and not necessarily a scope of practice issue. We understand that there are discussions with the legislative network and the proponents of the bill relating to which training would be sufficient and which wouldn't. We chose not to get into that debate and just support the bill on its merits up front.
And so, Mr. Sposato, is it fair to say that within the network, there may be a diversity of views within the members of the network? A sign-off of the network certainly does not mean that each individual member shares the overall view of the network.
I believe that's correct. I don't believe the network, Madam Chair, I don't believe the network works on total consensus. So I'm here to portray our position. It has no bearing on what the network has to say other than we are a member, one of the 31 groups or 33 groups, whatever it is that are members, and that our position had somewhat migrated to support after last year's debate and the year before debate on this issue. So we think it's time to fix it.
That's helpful to know, and probably good for future that members of the network hearing and other such things, that if there is a diverse view, that the individual members of the network make sure that their voice is known so that there is clarity for legislators and understanding the full ramifications of the decision. So, okay, and we have one final question from Representative Liebling.
Well, thank you, Madam Chair, and thank you, Mr. Sposato. I'm glad to hear of that support. That gives me a little bit more comfort. I just really wanted to say that I think that there's kind of no need to yell at Ms. Stark about it. I think she was pretty open and frank about her position, and I just wanted to clarify too what you just mentioned, that you know, there's been a migration of the society's position, and the bill has changed. The bill has changed. There didn't have 2,000 hours of practice in it before, and that I think is an improvement to the bill, because I was pretty uncomfortable with it before. But I think this has been a really good debate. There's no reason for anybody to get upset. I mean, it's an important policy question, and you know, one that I think reasonable people can disagree on. And I think it's helpful to have people kind of on both sides to help us clarify the issue, and the fact that, you know, it doesn't all line up easily all one way, and none of us can predict the future, and we can hope that it provides more access. We can hope that it provides quality access. You know, members can differ on that, and I think that it's just a very good discussion and very fair. You know, thank you for bringing the bill, Representative Albright, and I hope you don't have any holes in you after this hearing. Thank you.
Okay, final word briefly, Representative Albright, and we'll vote.
Thank you, Madam Chair and members. I do also share the desire to provide the best coverage possible. I think this is a best efforts opportunity to advance the case for those that are in most need, and I do hope that you lend your support to it, knowing full well that we will continue to work with the stakeholders going forward. Thank you for that.
Thank you. So Representative Albright will renew his motion that House File 1011 as amended be sent to the General Register. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Thank you, Representative Albright. And members, last bill of the day, Representative Zerwas. House File 1604.
We're at the end already, Madam Chair?
Representative Zerwas will move that House File 1604 be re-referred to the Committee on Civil Law and Data Practices. There is an author's amendment, the DE1 amendment. Representative Zerwas, do you want to move your DE1?
Madam Chair, members, I will move House File 1604 to be put in front of the committee to be referred to civil law. And then, Madam Chair, I will move the DE1.
Okay, members, Representative Albright, Representative Zerwas moves the DE1 amendment to get the bill in the order that he would like to discuss it. All those in favor say aye. Aye. Those opposed, no. The motion prevails. Representative Zerwas, two-year bill as amended.
All right. Madam Chair, members, House File 1604 is a bill that will help prevent needless deaths from simple things that seem really unthreatening to most of us. Peanuts, insect bites, and sadly, even buttermilk pancakes. Some may have seen a recent WCCO story about a Bemidji teen who just this past summer was passed away after eating pancakes that he thought were dairy-free, and it turned out it was not. He had forgotten his EpiPen, and sadly that day he died from a severe allergic reaction. Quite common, severe allergic reactions cause approximately 1,500 deaths annually, with children and adolescents most at risk. It's estimated that 1 in 13 children in the U.S. Has a food allergy. There are approximately 90,000 emergency department visits each year due to anaphylaxis, or the severe allergic reaction. And so this bill is just another addition to what we did previously. The bill we worked on last year permitted schools to maintain and use epinephrine autoinjectors for individuals believed to be suffering that severe reaction. This would allow additional entities to obtain the autoinjectors so that their trained staff may use them with individuals without a prescription if an emergency were to arise. The bill specifies that these authorized entities, as recreation camps, colleges, universities, daycares, preschools, the Department of Health has authority in the future to identify additional categories of authorized entities. And members, the important thing is this would be 100% voluntary. Any of these authorized entities could go through the training and request to be a part of this program. It doesn't mandate that anybody participate. The training would include how to recognize signs and symptoms of a severe allergic reaction, the emergency follow-up procedures, and then the training organization would provide a certificate that can be provided to a pharmacy licensed as a wholesaler or a manufacturer to purchase the epinephrine autoinjector to have available in the event that an emergency were to occur. The bill language also includes an immunity from liability for any entity acting in good faith under this law. When someone suffers an allergic reaction, timing is critical. Lives can be saved by having these autoinjectors available for use by trained individuals, and the more availability, the better. We've been working with all the stakeholders involved in this bill, and we continue to work. So I met briefly with MDH this morning and negotiations with them. There's a lot of work done before we introduce the language, and that work continues. They might have a few tweaks going into civil law, but at this point, they don't have any big heartburn with it. I have a few testifiers here, Madam Chair, and I'll turn it over for them.
Welcome to the committee, and thank you so much for being patient and hanging around all day waiting for this. But if you could introduce yourself and proceed with your testimony.
Thank you, Madam Chair. My name is Nona Narvaez, and I serve pro bono as the Executive Director of the Anaphylaxis and Food Allergy Association of Minnesota. Some of our documents are actually in front of you. There are 200,000 Minnesotans who have food allergies, 15 million Americans, and about 60,000 of those Minnesotans are children, school children. There are also Minnesotans that are allergic to insect bites, to medications, and this legislation would benefit them, and also those that don't yet know that they are allergic to something. For example, in schools, 25% of anaphylactic reactions happen in children that have not been diagnosed with a food allergy. So they obviously don't have the diagnosis, they don't have the prescription. And you can extrapolate from that that happens in the public as well. There's similar legislation to this that's being considered, that has passed in Oregon, Florida, and Rhode Island, and is being considered in California, Maryland, North Dakota, and Alaska. There they allow scout leaders and daycare workers to administer epinephrine. There are approximately 30 states that are now debating similar kinds of legislation that is before you. And places like Disneyland, Disney World, Disney ships, and all the Disney properties also have stocks of epinephrine for emergency situations in their first aid stations. So this is a natural progression of trying to save people's lives. Unfortunately, allergic diseases are increasing rapidly, and so it's something that you're going to see more and more of. We have large events at Mall of America. We have a booth at the State Fair. We have observed severe anaphylaxis in Target Field, where a teenager actually needed 2 doses of epinephrine, and obviously EMS was called for. They came quickly, but those seconds seemed like hours. So having epinephrine on site is something that different venues would really, really appreciate. And again, this is a voluntary piece of legislation, but it's wonderful to be able to allow different entities to have epinephrine if they feel that they need it. I just wanted to say there have been a couple of cases in food courts, one in Hamilton, Ontario. There was a fatality, and they then considered this kind of policy. There was one in Boston very recently. Unfortunately, that child did survive. I have my son here who was going to share his story, and I have a younger son too who is also dealt with life-threatening food allergies, and we have the auto-injectors trainers up here. If you are interested in looking at them, my younger son can pass them to the pages. Thank you very much, Madam Chair.
Thank you so much for being here. To the other testifier, welcome to the committee. Please introduce yourself and you can proceed.
Okay, my name is Mack Narvaez. I am Nona's son. I'm 16 years old, sophomore at Coleman Park Senior High School. And throughout my life, I've survived many anaphylactic reactions, some just worse than others. I've outgrown 6 allergens since I was young, but I'm still allergic to milk, eggs, tree nuts, beef, pork, fish, shellfish, and poultry, and that is quite a lot. Anaphylactic reactions can vary in symptoms and the time it takes for the reaction to actually occur after the exposure, even within the same individual. Anaphylactic reactions vary in symptoms so much that really if you have one person that you know them to get hives every time, but then they have their throat closing up another time, it's still the same reaction. So I myself have had reactions that have sent me to the hospital. One time I was in Spring Valley, Minnesota, about an hour south of Rochester. We were at a camp meeting with the food service director to see if I could safely eat some food when I attended the camp later that year. I had eaten some food at a restaurant in Rochester about an hour before going to the meeting with the food director. And when I started having an allergic reaction, I had a facial rash, watery eyes and nose, nausea, and then eventually vomiting. And they all gradually developed over the course of an hour as we drove to the camp. So my parents administered epinephrine, and the symptoms disappeared about 30 seconds later, and I felt much better in about 45 seconds. But the interesting part about that story is that I coughed once after the epi was administered, which means that could have led to a throat closing if we had not acted so quickly as we had. Another time I was having a salad, and I reached for a salad dressing, but it ended up being the wrong one. Same package almost, just one had egg, one didn't. And so I immediately realized my mistake and spat it out and rinsed out my mouth. But even then, my throat started closing. And so we administered epinephrine, and I got better almost right away. But that time, instead of it being over a course of an hour, it was about 1 minute after exposure that the reaction started to occur. So my throat closing meant that I soon wouldn't have been able to ingest oxygen or any more egg, which is what my body intended. So if my parents hadn't taught me to carry epinephrine, the 15-minute ambulance arrival time in southern Minnesota would have probably been fatal for me, because it was a while after we administered epinephrine until they got there. So just imagine if this happened to a camper that was just at a camp doing normal stuff, and they have a reaction. They don't know what is happening. So that, because as my mom said, the 25% of children in schools have their first time reactions. So people at the camp, they won't know what to do currently. So, or you could imagine an allergic college student who needs more than a single dose that they carry at all times with them, and sometimes the one dose will not suffice. Or somebody at the state fair, or the Minnesota Zoo, or a baseball stadium or shopping mall, all places where they have emergency care, which would usually have epinephrine, but still there is that delay between the time they're called and the time they're actually able to get there, usually because of crowds. So this is why it is important to let venues obtain non-patient specific epinephrine to use in case of an anaphylactic emergency, and it could save lives. Thank you.
Thank you so much for being here and sharing your story. We really appreciate it. Are there any other testifiers in the audience? Seeing none. Members, questions? First, we have Representative Franson and then Representative Freiberg. Representative Franson. Oh, I'm sorry. Excuse me. Please introduce yourself and you can proceed.
Sorry. Thank you, Madam Chairman. Good afternoon. My name is Eric Marsh, and I'm here on behalf of Mylan. Mylan has a subsidiary that markets and distributes one of the multiple auto injectors that are available on the market. And I'm here to offer my support in support of House File 1604. I think the other witnesses have touched on all the things that I was going to touch on, so in the interest of time, I'll just make myself available for questions if there are any.
Wonderful. Thank you so much for being here. Well, with that, Representative Franson.
Thank you, Madam Chair. You know, being on this committee, sometimes it's like being in college. You learn so much. And today, I appreciate you telling your story and enlightening the body about just how important this piece of legislation is. My question veers more as being as a mother at home. What if my own child, one of our children, had an attack at home where we did not realize that that there was a reaction of some sort that could take place? And I don't know the answer to this, so perhaps the Mylan rep would be able to answer, or maybe the mother up front. But you have to have a prescription for this, or you have to wait for something, because in greater Minnesota, obviously waiting for a car ride, one of my 3 children, if this happened, could die. Whereas if they're going to have a reaction, you would hope that if they had one, it was going to be somewhere where these were in public, which is, to me as a mother, very frightening that you actually have to wait for, instead of having a just in case on hand at home.
To answer your question, Madam Chair and Representative, it is a prescription medication for individuals, but because we passed the law in 2013, schools can stock it that's going to be non-patient specific, and this bill will also then allow it to be in public places to be non-patient specific. If your child starts to have allergic symptoms at home, you should call 911, because in 2002, our organization spearheaded a law here in the state of Minnesota to ensure that epinephrine is on all Minnesota ambulances. Before that time, about 3 out of 5 emergency calls, you would have gotten an ambulance rig without epinephrine. But we passed a law back in 2002 to make sure that it was in all ambulances. And one of the tragedies about the recent case up in Bemidji is that the family went home to get the auto-injector. And it could have been a different outcome, perhaps, if they had called 911, because that ambulance would have had epinephrine on board. time that my son was in Spring Valley and had to be transported back to Rochester. It was 10 years after that law passed, and I just had a shiver up my spine thinking if he needed extra doses of epinephrine, which sometimes happens for biphasic reactions, that ambulance had the epinephrine on it because of the law we passed.
Representative Franson?
Madam Chair, it's still my issue is at home, still waiting in Greater Minnesota. An ambulance ride can be the matter of life and death, so.
If you are suspicious, Madam Chair, Representative, if you are concerned about your child possibly being allergic to something, consult with your pediatrician and with an allergist. Generally, there will be some kind of history with symptoms, and you can ask a medical professional to test. There are some very simple tests out there. Blood test, one simple draw, and you can test any kind of allergen that you're suspicious of. It can be any of the major 8 allergens, and it can also be, things like strawberries or potatoes or rice or whatever you are suspicious of. So if you think there might be something going on, by all means, consult with your medical professionals and press for some testing to find out.
Representative Freiberg?
Thank you, Madam Chair. Not sure who the best person to answer this question is. I noticed there's a provision in the amendment that allows the commissioner to issue a certificate to each person who successfully completes the training program. I don't see any process in there for renewal or anything along those lines. I don't know if this was discussed with the legislation related to EpiPen use in schools 2 years ago. I'm just wondering, what if that certificate is good forever? What happens if the procedures for administering this changes and if some new training is required?
Representative Zerwas?
Madam Chair, members, great question, Representative Freiberg. And that's one of the things, as I've been told, as negotiations continue with MDH, that's one of the things that is kind of going round and round is where that's going to end up. But it sounds like some type of renewal or length provision will remain. That being said, the certificate basically is to show, I know the basics on how to spot a reaction. I know what it does, what it doesn't do. I know the steps to follow as far as still calling 911 and still following up on that. And I know how to administer the basic use of the EpiPen. Now, as things change and new technology comes out, that would, of course, not null and void the basic training that the individual would have received in doing that. But I'm being told that negotiations are ongoing with that piece of it yet.
Representative Fisher?
Thank you, Madam Chair. And first of all, I want to thank the author for bringing this bill forward. As a father of a child who falls into this category, who doesn't always remember to bring their pen along, who's in colleges, I can see the need for it. So I express my support for it, and thank you for doing this.
Representative Liebling?
Thanks, Madam Chair. And my question kind of follows on Representative Freiberg's, but it's a little different. I don't really understand why we'd need to require the training at all in order to have the EpiPen. I could see where the training would be good. It would be great if people had this kind of training. But to my knowledge, and I carry one, everybody knows, because I'm allergic to bee stings, right? And just like I said last time we had a bill like this, it's winter, there are no bees, I'm still carrying it, and it's because somebody else might need it, right? And I have it, I'd use it. And if I thought someone was having the reaction, and if I was wrong, it's just a little epinephrine, right? So sort of like what we did with Narcan. It's so harmless, I think, maybe I'm wrong. I'd rather have people have it, even if they didn't have the training. So I'm a little puzzled why we're going to sort of require this layer, with and saying it is great. I mean, it's great if they have to have, it's great for them to know this stuff. It's great for people to have the training. But if they don't, I'd still like them to have the epinephrine.
I think the training is important for recognizing the symptoms. And let me give you an example. When, Madam Chair, Representative, when my son was having the reaction in Spring Valley, he had a butterfly rash, he had watery eyes. It was May. I assumed it was a hay fever kind of reaction, or that he was coming down with a cold. It did not click in my brain that he was having the beginning of an anaphylactic reaction. And I had just lectured in Rochester. I was substituting for a Mayo Clinic physician doing a presentation only 2 hours before, and yet I didn't even recognize at first that he was having an anaphylactic reaction until he started to have the stomach symptoms. Then my brain put 2 and 2 together. And I spoke to my husband about it. I said, we need to give him epinephrine. And even my husband was saying, are you sure? Maybe it's just the flu. Now, we have worked in this field for 12 years in the nonprofit, and yet we had trouble recognizing the reaction for what it was when it first began. And fortunately, we gave him the epinephrine. It reversed the reaction immediately, and that was the right course. So I'm just saying that even I made the mistake of not recognizing it right away. So I think it's important because a lot of people will mistake things. They'll say, oh, I see no hives, therefore it's not an allergic reaction, when it could be other body symptoms that are reacting. It could be stomach, it could be throat, it could be edema where you've got swelling of the lips. And you can have any number of those symptoms. You can have sometimes in combination. You might not have any of the same symptoms you had before. The last reaction my son had, his throat was closing. He had no skin symptoms. He had no vomiting, but his throat was closing. So even in the same individual, the symptoms were different. So I think that's why the training piece is important, so that they learn to recognize the symptoms.
Madam Chair,
Representative Zerwas.
and to be quite honest, Madam Chair, members, Representative Liebling, we will be sure to tell the Department of Health that that's the opinion of some people in the committee, because I think we don't want to make this any more burdensome than possible. But we've been working very hard to work in good faith to get to an agreement that everyone felt comfortable with. And so as those talks continue, as we continue to collaborate on this, I'll be sure to keep you abreast.
Great.
Representative Liebling.
Thank you, Madam Chair, and thank you to the testifier. You know, I can see that, you know, again, training would be very, very useful, but I would so much rather just have the people make, you know, if they didn't get the training, so they didn't have the epi, then, you know, then they can't help at all. So I just would rather err on the side of, you know, so I thank you, Representative Zerwas. I think it would be great to push the department to give the minimal, to require the minimal that would, to make it reasonably safe to have and use, and then offer more. You know, offering more would be terrific, and encouraging more would be terrific. But boy, I'd sure rather have them have the epi and be untrained than not have the epi because they're untrained.
Madam Chair.
Ms. Narvaez.
Thank you. Madam Chair, Representative Liebling. Minnesota is one of only 2 states in the United States that actually has a Samaritan, a clause in the Samaritan law that requires that bystander assist if they know what to do, or if they, you know, can in good faith actually do something. So in the scenario that you present, they should just grab epinephrine and help, even if they haven't gone through formal training and gotten a certificate. And these auto-injectors were made for public use, for lay people to use. So that's why they were developed in the first place. Thank you.
Okay, members, Representative Loeffler, final question.
Well, thank you, Madam Chair. And members, I just want you to know that we've been joined by an illustrious group of young leaders. They're the student council members of Waite Park School, and while it is an integrated school with boys and girls, only the girls chose to come here. I think that shows some real leadership as well. I graduated from Waite Park a long time ago, and I told them about this bill and consulted with them, and they thought this sounded like a really good bill to help protect kids who might have an allergy and be in trouble. So I just thought I'd share their advice with the group.
Thank you, Representative Liebling, and thanks for bringing him in. Thank you for being here today, you guys. It's really nice to have you. And Representative Zerwas, you've got a ringing endorsement, it sounds like.
Madam Chair and members, in closing, I don't want to screw that up. That's a good endorsement, so I'll renew my motion, Madam Chair.
Okay, Representative Zerwas will renew his motion that House File 1604, as amended, be re-referred to the Committee on Civil Law and Data Practice. All those in favor, please signify by saying aye. Aye. Those opposed, no. The motion prevails. And members, just really quick, before we scurry about to head out, we do have to briefly reconsider Representative Albright's bill that we just heard, House File 1011, because it actually needs to go to Health Finance first. And so I am wondering, or would like to make a motion to reconsider that and then make a motion to re-refer it. So my first motion will be to reconsider and bring back before the committee House File 1011. All those in favor say aye. Aye. Those opposed, no. The motion prevails. And so members, House File 1011 as amended is back in front of us, and I will move that House File 1011 as amended be re-referred to the Committee on Health and Human Services Finance. All those in favor say aye. Aye. Those opposed, no. The motion prevails. And members, that concludes our business for today. And so our next hearing will be on Monday evening at 5 o'clock. And with that, members, we are adjourned.
I think it will be.